Hello, I'm Alan Weil, Editor-in-Chief of Health Affairs. Thank you for joining us today for our briefing entitled Rational Healthcare Spending Growth. Can we get there from here? Today, we're pleased to share with you the recommendations from the Health Affairs Council on healthcare spending and value. Now, the United States is an outlier among nations, not only in how much we spend on healthcare, which is well known, but also in the absence of any collective mechanism to restrain how much we spend or ensure that the spending produces the most desirable possible health and well-being outcomes. It's in this context that Health Affairs launched the Health Affairs Council on Healthcare Spending and Value, which is an outgrowth of our decades of scholarship on the topic. If you go back to the very first issue of Health Affairs, there were articles in there looking at how much we spend. And over the years, we've published a great deal on concerns about rising spending on healthcare services. Now, this nonpartisan, multidisciplinary expert working group was chaired by Bill Frist and Margaret Hamburg. It was formed to promote a nonpartisan, evidence-based approach to understanding what we spend on healthcare, what benefits we receive from that spending, and how we can achieve more from our investments in health. Based on those goals, the Council developed recommendations about how the US could take a more deliberate approach to moderating healthcare spending growth while maximizing value. In the briefing today, we're going to explore and build upon those recommendations in 4 categories: administrative streamlining, price regulation and supports for competition, spending growth targets, and value-based payments. Now, during the briefing today, we hope to accomplish 2 things. First of all, we want to introduce you to the Council's recommendations. The Council covered a lot of ground. These are complex problems. We're going to only be able to provide a high-level overview of the breadth of the topics covered by the Council, and then we'll take one theme out of each of these and go a little bit deeper. We're also, with this event, kicking off a series of discussions in 2023 that will go into these topics in more depth. So you'll be able to hear more about some of the topics that we don't cover in great detail today. Before we move into the content, a few words about the Council. As I mentioned, we had the leadership of Dr. Peggy Hamburg and Senator Dr. Bill Frist, both of whom you'll hear from today. These names, I assume, are familiar to most of you, but just so you know, Peggy Hamburg is an internationally recognized leader in public health medicine, biomedical research and innovation. She's the interim vice president for biological programs and policy at the Nuclear Threat Initiative. She was recently the Foreign Secretary of the National Academy of Medicine, was the chair of the AAAS, the American Association for the Advancement of Science. She has been the commissioner of the US Food and Drug Administration, the Assistant Secretary for Planning and Evaluation at HHS, Commissioner of Health for New York City, and more. Senator Bill Frist is heart and lung transplant surgeon, was the majority leader in the United States Senate and a founding partner of Frist Cressy Ventures. He represented Tennessee from 1994 to 2006, the first practicing physician elected to the Senate since 1928, involved in critical legislation in healthcare, particularly the passage of the 2003 Medicare Modernization Act that established Medicare Advantage, and the creation of PEPFAR, which has provided life-saving treatment globally to tens of millions of people. Takes a lot of work to make a council like this succeed. Laura Tolan is the council director and senior editor at Health Affairs. She will be leading one of the sessions later today. And Elizabeth Keating was a consultant on the project who helped us substantially with the research and the writing. And before you can see the council members up on your screen, before I refer to them, I do want to particularly acknowledge Bobby Du Bois, who is a member of the editorial board of Health Affairs, formerly the president of the National Pharmaceutical Council. It was his and my joint idea, I think it's fair to say. We crafted this some years ago to create the council, and his leadership and guidance has been critical throughout. He is now retired. You see now the list of the council members, a variety of perspectives. We did ask people to participate as individuals, drawing on their expertise, not to represent specific organizations. And to be clear, the recommendations that we have put in our report and are releasing today do not necessarily reflect the positions of the member organizations, Health Affairs, Project Hope, our publisher, or any other organization. We did not have a formal consensus process. We did our best to craft recommendations that the members could get behind. There is one area where we did not achieve that, and there's a minority report on that topic. But I do want to be clear, no individual member of the council should be tagged with supporting any individual element of the report. This is designed to capture the deliberations, but not speak for the members. They are all fully able to speak for themselves. So what are we going to do today? We're going to have a welcome from the council's funders, and then you'll hear from the co-chairs who will talk a little bit about what we set out to do and how we went about doing it. We'll then go into 4 sessions in the 4 categories of recommendations that I mentioned. We'll have a member of the council and 1 external expert, not a member of the council, discussing one portion of that theme. As time permits, we will build in audience question and answer. There is a Q&A box at the bottom of your Zoom screen. Please feel free to submit questions at any time during the event. The earlier they come in, the better. If they're pithy, that makes it easier to weave them in and to read them while we're also running the show. And of course, questions of broad interest are going to be more likely to get asked than one that is narrow. We are recording the event. It will appear on the website within a couple of days for those who can't watch us live. So now we have a lot to cover. I want to begin by turning to the 2 organizations that funded our work, the National Pharmaceutical Council and Elevance Health. I'll turn first to John O'Brien, I believe, although Jen is up on the screen. I'll turn first to John O'Brien, President and Chief Executive Officer of the National Pharmaceutical Council, which sponsors and participates in research on the appropriate use of pharmaceuticals and clinical and economic value of innovation. He's been a senior advisor to the U.S. Secretary of Health and Human Services, Deputy Assistant Secretary of Planning and Evaluation, has worked at CMS, and has been a great partner for us. John, I'll turn it over to you.
Well, thanks, Alan. And Jen, you should certainly come on screen. I'm always grateful for the opportunity to stand beside you. And thanks, Alan. The National Pharmaceutical Council, as you said, is a health policy research organization supported by pharmaceutical companies. And we turned 70 years old this year, and convening experts to advance important conversations like this one has been a big part of our work since 1953. I am incredibly proud to join with Elevance and the Public Policy Institute there in supporting this work, and also want to double down on thanking Laura and the Health Affairs team, as well as all of the panelists who made this work possible. Just looking at the participants list, I see some friends and health policy luminaries on the call, so kudos for pulling together a great audience. I would also like to echo your shout out, Alan, of the prolific Bobby Du Bois and his work in getting this ball rolling before retiring from NPC last year. As you'll hear today, considering health spending is an important topic, not just to the Academy, but to policymakers working on the myriad issues we'll discuss. I am really looking forward to not just hearing the conversations today, but seeing how this work influences future conversations. And Alan, I can't help but note that policymakers are presently working on implementing another big statute, and can't help but think that this would be a good model for studying that process as well. So thanks again for the opportunity. Look forward to a great day. And Jen, I'll turn it over to you. Or Alan, to introduce you, perhaps.
Yes, I've been taken off video, but I didn't get to introduce Jen. So let me do that by voice, even if not on the screen. Here we go. And I'm back. Jennifer Kowalski is the Vice President of the Public Policy Institute at Elevance. The Elevance Public Policy Institute works to advance meaningful change in healthcare through publication of policy-relevant data analysis, research, and insight. Jen has been spent time at Avalere and was a consultant at the Lewin Group and has been another great thought partner for us. Jen, over to you.
Great, thanks, Alan, and thank you, John, and welcome to everyone joining this event today. I just want to start my brief remarks by also sharing my thanks and appreciation to all the many individuals who contributed to the council, who supported the work of the council over the last several years and really made the report, but also today's event possible. A big thank you as well to the health affairs staff, especially Alan and Laura, Elizabeth, Debbie Boylan, for all their work in bringing this group together. It certainly wasn't easy, I think, to synthesize the input of 24 different council members rather, and really craft this excellent final report that's reflective of all those efforts. I also want to thank the council co-chairs, Senator Frist, Dr. Hamburg, for their expert guidance, and of course, all of my fellow council members for graciously giving their time and expertise and creative thinking to this effort. It's really been a privilege and actually quite fun. I'm going to miss it to be part of this esteemed group of colleagues over the last several years. And of course, finally, a thank you to John and to Bobby and our co-sponsor, the National Pharmaceutical Council, for their collaboration on this project. And, I think for Elevance Health, our decision to co-sponsor this important effort was really rooted in our commitment to advancing whole health. And so thinking about, how do we improve affordability, quality, equity, access to healthcare for individuals and for the communities in which we are. And I think these are critical areas of importance, of course, not just for us, but for our consumers and our partners as well. So whether that's employers, consumers, providers, state and local governments, and federal policymakers as well, we're all focusing on how to improve affordability, how to improve value. And so I think in standing up this council, Health Affairs really was able to spur some bold and thoughtful dialogue about our nation's healthcare spending, really, kind of dig into whether we're getting good value for that spending and how the healthcare system could evolve moving forward to do better. And so I hope that the work of the council, the report that we're going to talk more about today, will also provide all of you with some interesting insights, kind of raise some important questions for your consideration, and also perhaps spur some new and innovative ideas that you might include in your own work. And so I'm really excited for the conversation today. And with that, I'll turn it back to you, Alan.
Thank you, Jen. So we're now going to move into discussion of the council and its work. I should have said earlier that the council is discussing the recommendations today. The report is being released today and is available on our website. Without further ado, I've introduced our two co-chairs. I'll turn it over first to Peggy Hamburg to talk about the process the council followed.
Thank you very much, Alan. And let me begin by saying how pleased I am that we can all be together today to discuss the recommendations of this Healthcare Spending Council report, and begin by thanking the funders for making this possible. Echo also the thanks to the Health Affairs team for their hard work and their intellectual and substantive contributions to the work of the council. Of course, also my friend and colleague and co-chair Bill Frist, and the members of this distinguished panel. I'm in a hotel room. I apologize. I knew that something would go wrong, and it went wrong right at the beginning. But my charge right now is to give a brief overview of the council process, and to begin with the charge to the council, which was to recommend ways that the United States can take a deliberate approach to moderating healthcare spending growth while maximizing value. Next slide. The council was very deliberate in our discussions and very collegial too, I would say, but reflected many different perspectives and very substantial experience on the part of the members of the council. I apologize, the phone is ringing here. Oh my goodness. So, first we really had the discussion began, focusing in on the drivers of U.S. healthcare spending and the fundamental question of how to define excess spending and growth. The important questions of, is spending too high? Is growth too high? Obviously, no absolute answers. You can't say what the precise percentage of the GDP healthcare spending should be. But we dove into the literature on trends, looked at international comparisons, and spending drivers. And, certainly the question of how best to define excessive growth or spending, really we came to from a values concept, and that it was that which is not commensurate with the value of the health it produces. And to quote from the council report, the council believes that the current expenditure and rate of growth are higher than they should be, as they are disproportionate to the health and equity they produce and represent a significant burden on families, employers, employees, and government. Next slide. So we eventually set as our formal goal to achieve higher value healthcare spending and growth in the US, which is just a little bit modified from the initial charge from Health Affairs, which was to address how to moderate spending and growth. But we were able to come up with really 4 quite realistic and meaningful areas of focus and recommendations. Alan spoke to those, but also we defined 4 levers for achieving the goals, looking at price, paying the most efficient price for care, volume, ensuring the appropriate quantity of care, mix, ensuring the appropriate types of services for given patients and populations, and growth, growing the price and volume sustainably and maintaining an appropriate mix over time. Next slide. As we thought about our categories of recommendations and the necessary interventions, we thought about our selection criteria from various vantage points. We wanted to focus in on recommendations and interventions where meaningful money was potentially at stake, that would really make a difference, that would likely be feasible to address in terms of the spending drivers through policy interventions and either modifications in programs, new programs, and policy frameworks that could be put into place and implemented. And of course, we wanted to draw on the unique expertise and perspectives of the council members and really make a powerful contribution to the debate about the specific recommendation and intervention that really drew on the value of our council in specific. So as was mentioned earlier, we ended up with 4 categories for recommendations: administrative streamlining, price regulation and supports for competition, spending growth targets, and value-based payment. This next slide is a little bit confusing, but I think it's actually useful because it shows how the 4 recommendation categories map to the 4 levers for achieving high value spending and growth. Our feeling was that collectively the recommendations must address all 4 levers. If not, improvements in one area might end up contradicting other interventions or actions, either inadvertently or intentionally. But clearly some levers are more targeted in focus and impact and pull only 1 or 2 levers, and others are more systemic and pull several levers, the recommendations, that is to say. So both types are needed. Let me say also a little bit in my time that remains, next slide, about what we did not include. It was hard. We set out with a very big vision and an important goal, but we couldn't do everything. And we, as I mentioned, wanted to really draw on the special expertise and experience of our council and the moment of opportunity that we had. So one of the areas we discussed but did not focus on in our report and recommendations is low value care. Clearly an important area, an area where we know there is very, very considerable waste in terms of spending on healthcare interventions that are not of meaningful value to patients. Some estimates of cost of overtreatment with low value care actually range from 176 billion to 226 billion. So certainly an area that needs focus, but we didn't make formal recommendations, partly in deference to the work of expert groups with a longstanding focus who were much better positioned to really add value in this area. But we did feel that some of our recommendations actually would address low value care indirectly through spending growth, target setting, and value-based payment. The second big area was social determinants of health. And we've long known that so many of the things that are really important for health happen outside of the healthcare delivery system. And increasingly, we are aware of that due to the experience with COVID, which really shone quite a bright light on this set of issues. So although social determinants clearly shape health, we really found it much harder to understand and directly assess how they shape healthcare spending. And while we felt this was enormously important and deserves, and we hope will get continuing focus and attention, we felt that it was outside of the council's scope for this work effort. But we hope that by addressing issues within healthcare itself, we may also lay an important foundation for work on social determinants of health to continue to go forward and link in to our healthcare system. And finally, pharmaceutical spending. We all know how important this is. It's very much, of course, on the mind of the public and also a major debate in policy setting spheres. But we chose not to make recommendations in this area because we were not really looking at specific sectors in isolation, of course, recognizing that all of the different sectors that are part of the broad healthcare ecosystem are interconnected. But we recognize that the pharmaceutical markets are quite different in terms of their frameworks and their incentives, and they have a different regulatory structure from markets that are part of other components of the healthcare system. And while, again, we feel it's an enormously important area, that we hope that some of our discussions will help contribute to ongoing work in this area, that it wasn't an area for us to focus on specifically and make recommendations. So some of you will be disappointed that we didn't focus on these areas, but as you will hear and eventually read, I hope, when you get your hands on this report, we did cover a lot of important ground. And I'm going to turn now to Senator Frist to talk briefly about the recommendations. Over to you.
Good, Peggy, thanks so much for outlining our council approach and introducing our recommendation areas, which we will be elaborating upon. And good afternoon to everyone. I'm going to provide some more detail on each of the levers within our 4 priority areas. The first, administrative streamlining, was selected because the research indicated a substantial amount of waste in this category of spending. Estimates attribute 15 to 30% of total national health spending to be in this category of administration, with experts estimating that at least half of that spending is ineffective or wasteful. And that means as much as $200 to $600 billion is wasted each year. Now, we all know that nations with single-payer health systems have notably much lower administrative healthcare costs than the U.S., but our goal was not to reach those levels, but rather to focus to eliminate wasteful spending that does not add value to our current multi-payer system, the multi-payer system that we have in our country today. And in all of our deliberations, it was reflected in that we are mindful of Americans' preference for choice and having that choice. The following levers that I'm about to outline are smaller but really actionable steps that can help build this momentum over time for taking much larger steps in the future. So, administrative streamlining, let's just dive right in. Recommendation A1 is what we consider some of the low-hanging fruit out there. It includes 4 processes to standardize data flow. The first is data collection for provider directories. It's currently estimated that maintaining provider directories cost physician practices up to $2.8 billion annually. We recommend using a single platform to exchange directories information, and that would save U.S. practices at least $1.1 billion per year. The next lever is data collection to support credentialing of providers. Using a single platform to facilitate credentialing with multiple health plans can save the clinical practices almost 40% of the credentialing cost per month, while simplifying the process tremendously. A third recommendation in this category is centralized claims processing. This one is modeled after the banking industry's automated clearinghouse, which allows for the secure, and we all take advantage of it every day, but the banking has demonstrated a secure, standardized transfer of money or other financial products between 2 parties. A centralized health claims clearinghouse would standardize the electronic transmission of billing information across providers and payers. And we found that it could save $300 million per year. Harvard healthcare economist and council member David Cutler, who is with us today, has extensively researched and advocated for this approach, and he'll share some great insights on this in just a bit in today's program. The fourth recommendation is data collection to support prior authorization, and those clinicians out there today know what that means. Prior authorization is an important but hugely burdensome process that is often still done amazingly by telephone or even faxes instead of electronically. We'll see that some states are already taking the lead in simplifying. Finally, in this category is recommendation A2, which recommends longer-term harmonization of quality measurement. We at the council widely, of course, support quality and data and measurement and measures. But we agree that the quantity and diversity of all of these hundreds and thousands of metrics today detract from our ability to interpret data effectively across systems. These are unnecessary burdens on providers. You know, things like CMS uses more than 2,200 metrics. In this quality world across its programs alone, 2,200. This is clearly an area that can be harmonized and can be simplified and can be streamlined. And granted, it will take coordination among many stakeholders. The next area that council recommends action in is price regulation and supports for competition. And we'll be talking a lot about competition over the course of today. My mentor and renowned healthcare economist, Dr. Uwe Reinhardt, famously said of our healthcare system, "It's the price is stupid." I've heard him say it 1,000 times, as so many of you. This was also the title of 20 years ago, 2003 Health Affairs piece that he co-authored that attributed the sizable differences in our nation's healthcare spending when we compare ourselves to other countries to those vast differences in prices. Our healthcare costs more because we pay more for it. We spend more on it. You know, we have this free market system, yet large scale industry consolidation, the lack of price transparency, the misaligned payment incentives, the asymmetric information in the market between providers and consumers or patients and doctors and markets. All of these things prevent natural market forces from keeping prices competitive. The council concluded that in some settings, regulation of prices could be beneficial to slow the growth of prices, but must be prudent in application, recognizing that regulators can also get it wrong. Our goal is to curb excessive prices. Preference is to improve competition to do so, and then the second choice would be regulation. So let's take a look at how we do that. And we have 4 recommendations in this priority area. The first is the foundation for the other 3 recommendations and is broadly focused on improved state and federal monitoring of competitiveness. The following are the remaining 3 recommendations propose action based on the size and the diversity of the market or region, recognizing that they're very different areas. We put it into 3 categories. Recommendation B1, increased state and federal monitoring of market competitiveness. Now, this requires more funds, we know, and expanded authority, we know, and more scrutiny of the proposed mergers, and can be undertaken by states, by the Federal Trade Commission, by the Department of Justice. There are a number of sort of bodies that can actually look at this. If you go to recommendation B2, we have the limited price regulation, and those markets, again, part of this segmentation, that cannot be competitive. That's the reality today. The markets where the population, for example, is too small to support multiple competitors, where there are natural monopolies. In this category, the council supports states in setting all payer price maximums. Now, this can be calculated in multiple ways, which we talk about in the report, including things such as a percentage of Medicare price levels in chosen benchmark markets. Recommendation B3 is the conditional price regulation in a separate segment of markets, and markets that could potentially be competitive, but are not competitive today. In markets where the population size, say, is sufficient to support at least some moderate competition, steps can be taken to foster competition, encourage competition through a whole range of things. Incentives for additional market entrants, which for many is the preferred approach. Implement performance improvement plans for firms engaging in anti-competitive behavior, or by breaking up existing monopolies in the region. Easing licensure requirements to expand telemedicine and telehealth and virtual care could also increase this provider access and competition in these areas. Last in this category is recommendation A4, the additional support for competition in markets that currently have competition, that are currently competitive. In markets that are already competitive, and you think of urban areas with large populations, the council does not recommend price regulation, but rather increased monitoring of competitiveness and merger activity in light of the current climate. Next, the council considered action on healthcare spending growth targets. Studying the positive outcomes of Maryland's all-payer global budgeting system, and we also looked at Massachusetts all-payer spending growth target setting, the council supported state action to take on similar endeavors. Maryland's model, which was one of the 2 that we concentrated on, had particular success, where a governing board sets annual global budgets for all hospitals in the state. And Medicare spending has grown by 2.8% less compared to hospital markets in other states. And that's over a 5-year period. Other states that we have listed on the table here, the slide here, are taking action on this front. And yes, the jury is still out on the impact on spending growth, but many council members were optimistic and saw other benefits, like creating a shared commitment to spending and to other goals. Council has 4 recommendations to enable the approach of this spending growth targets. We have recommendation C1, data-supported target setting. States here are encouraged to develop healthcare spending growth target rates relative to the size of their own economy and informed by broader state care goals. And this can be done individually and in coordination with other states, or it can be done with the federal government. And the mechanism can be a commission similar to those used. And that's where it is useful to look at Maryland or to look at Massachusetts and take learnings from them. Or it can be through other dedicated or pre-existing structures. Governance must be by diverse stakeholders and must have public transparency. We came back to that again and again. Recommendation C2, data-supported monitoring of performance. States adopting these spending growth targets should develop a monitoring entity granted power through legislation, or it can be granted through power through legislation, or it could be by executive action. But the monitoring would be there, this entity, to compel data from stakeholders and track performance relative to the target. Recommendation C3 that you see, data-supported enforcement of targets. For targets to be effective, there needs to be some sort of enforcement mechanism. We came back to that again and again. The enforcement mechanism, they can vary, and we studied a lot and discussed a lot of them, but it could vary on the entity, whether it's the payer or the health system, the desired outcome, and can include public reporting of data, public justification of spending or prices, performance improvement plans, or direct fines and other penalties. The final recommendation in this category C4, federal support for data infrastructure, this federal support. The data infrastructure needed to implement spending growth targets costs a lot. It's costly. It requires specific training, highly trained staff. We recommend federal support for states committed who come forward and say they're committed to undertaking this work. It's where the federal government typically does very well when they get into this sort of responsibility. The federal government can also provide things like common data standards and dissemination of the best practices from one state to states around the country. As Alan mentioned, I'll just mention it again because it applies to this particular area. In our report, there is a minority report. It should be noted that there are some council members raised concerns about this approach, recognizing that there's a huge diversity of states in America, and some states just may not have the political climate. Some states may not have the infrastructure needed from the state standpoint to implement. And that some people felt that it's too soon based on the available data today, the good data, not a huge amount of data, but on the data today, it might be too early to encourage states to set these targets uniformly, within every state in the country. And that's where this minority opinion is included in our full report. So take a look at there. It's in the report, and you can look at that because it has some important points in that. Let's say I guess with that, I'll just say the council generally supports states taking the lead without any federal mandate or requirement. But we do recommend federal coordination, federal support to ensure this interoperability of these state efforts. So finally, in the next slide, the council agreed that value-based care is perhaps the only systemic intervention available that can simultaneously address price and volume and mix and the growth, the four dynamics we looked at, the lens through which we looked into all of our issues of healthcare spending. But from the data available, it's clear that further experimentation with the models is needed. As the literature has shown, savings to date from value-based payment have been real, but they've been modest, with ACO's savings ranging from less than 1% to more than 6% of total per person spending in Medicare. They're varied reasons for this, including the voluntary nature of value-based payment models. For those who opt in, believe they can financially benefit, while those who anticipate losses frequently choose not to participate. That said, we jointly recognize that fee-for-service cannot be the future if we want a fiscally responsible healthcare system. The council has several recommendations to further evolve value-based care to increase engagement and effectiveness and long-term savings. Recommendation D1, continued evolution of value-based payment models. We recommend 1, fewer models and better alignment among payers, which is consistent with the CMMI priorities. 2, stronger incentives for patients to obtain care from accountable delivery systems. 3, increased levels of financial risk and clinical risk, which enable more delivery system flexibility and nimbleness. 4, exploration of incentives for addressing non-medical determinants of health. And they've been mentioned, things like housing and food and transportation assistance. Now, before today, we turn to the panels for discussion of these. I want to note that the council's overarching goal, as Peggy laid out from the outset, has been to achieve higher value healthcare spending and growth in our nation. Over our 4-year period of collaboration and study, the pendulum of health spending has swung, as we all know, from support for reductions, swung to substantive, huge federal spending growth to combat the pandemic and its ramifications. And now the pendulum today swinging back as we enter a new Congress that is facing a debt ceiling debate that could hinge on federal entitlement spending. So while the national mood and political willingness at both the federal as well as the state levels will continue to shift over time, it's just a part of the rhythm of society and political and economics. The recommendations of this council can be applied for years to come. And now I'll turn it back over to Dr. Hamburg, who will kick off our first panel discussion on the administrative streamlining recommendations.
Terrific. Thank you so much, Bill. And our first session, we'll look at recommendation 1 on administrative streamlining. And we're very fortunate to have 2 terrific discussants. David Cutler, who is a member of the Health Spending Council, but also Margaret or Peggy O'Kane, who is joining as an expert outside perspective as well. So let me introduce them both, and then we'll get on with our discussion. David Cutler, probably known to many of you, is the Otto Eckstein Professor of Applied Economics at Harvard University. He served on the Council of Economic Advisors and also the National Economic Council during the Clinton administration, and was senior healthcare advisor for the Obama presidential campaign. He's a research associate at the National Bureau of Economic Research, a member of the U.S. National Academy of Medicine, and also a member of the Massachusetts Health Policy Commission, created to help reduce medical spending in that state. And Margaret O'Kane, who, like me, also calls herself Peggy, is founder and president of the National Committee for Quality Assurance, an organization founded in 1990 to improve healthcare quality through the administration of evidence-based standards, measures, programs, and accreditation. Peggy is also a member of the National Academy of Medicine, a board member of the Milbank Memorial Fund, and the Institute for Exceptional Care. In addition, she's a member and former board chair of HealthWise, a nonprofit organization that helps people make better health decisions. So thank you both for joining us. So we really want to hone in on recommendation 1 on administrative streamlining. And as Dr. Frist so ably laid out, it really had two major areas of focus. One was sort of the low-hanging fruit, things that can happen more easily and in a quicker time frame, and then the things that are more significant but longer term, what our colleague Laura Tolan used to like to call the Big Bang recommendation issues. The first one, low-hanging fruit, really looking at streamlining data gathering processes for provider directors, provider credentialing, prior authorization, claim submission, et cetera. And then the Big Bang, the longer run recommendations, looking at more systemic issues, streamlining quality measures and measurement processes. So let's first start with the low-hanging fruit. I'd like to really ask both of you to speak to how streamlining these processes is relevant for quality, and of course, in that, how doable is this near term? So, David, first to you.
Thank you. And let me just say, it's such a pleasure to have worked on this report and now to be here. It's really a great tribute to everyone, including you, Peggy, and Senator Frist and Laura and Elizabeth and everyone. So thank you. We put things in those categories of low-hanging fruit and sort of more Big Bang. Of course, nothing in healthcare is easy. So that's the first thing, that like even low-hanging fruit involves sort of climbing up the ladder and reaching high. But there are things that we kind of know in a more straightforward way how to go about doing them. And so there was not, like in the council, there was not a lot of debate about, would it be a good idea if provider directories were easier to, maintain and access. So of course it was, of course we should do those sorts of things. Many of them are things that just haven't happened because they've never risen up on the scale. We talk in the report about the cost impact, but the real question, of course, is the quality impact. And not the real question, another question. And I think if we think about quality in a number of different dimensions, these will actually have various benefits. One is, of course, the dimension of like standard measured quality metrics. And some of these bear directly on that, like the ability to move information and what can be done from that. Others are sort of not in what we think of as the standard quality metric, but will absolutely have implications in terms of the quality of the system. So for example, patients get extremely frustrated when they are recommended to find a specialist and they can't. And then the provider directory is out of date. And, some of the docs who are listed in there are not taking patients anymore, or they're not taking patients from that plan or so on. So there's this frustration and that turns into a quality. That's both a quality problem itself, and it turns into a clinical quality problem because then people give up and they say, I just can't figure out how to deal with it. There's also enormous issues associated with physicians, and they're sort of like, why am I spending all this time doing administrative things? I went to medical school so I could treat people, not to do administrative things. Same thing with nurses. Why am I spending all this time doing administrative stuff? And so there's this sort of outlook. There's both the wasted time that they could be devoting to other things, and there's the outlook, like the burnout and the just intense frustration. We're dealing now with a healthcare system where quality has in some ways deteriorated because so many people have left the system, nurses and techs and so on. And some of that's because of burnout. So this will help reduce that and bring the quality back, even as it lowers some of the costs. So I think on the whole, these are all cost recommendations, as well as things that will affect quality, both clinically, but particularly in just the sort of user experience, which is horrible and could be better, and that will also affect the quality of care.
Thank you. And as you pointed out, as you began, nothing is easy in healthcare, and it only seems to get harder. And of course, we're coming through, a rather extraordinary time with unexpected demands on our healthcare system. But Peggy, maybe you could give your perspective on this set of issues around streamlining the processes that are needed, and how to really grapple with this issue of administrative streamlining, which has certainly been a discussion for a long time. Efforts have been made, but we, even on the low-hanging fruit, haven't made the progress that we would hope.
Yeah, thank you very much. I think, yes, there's a great case to be made for these non-value adding redundancies. I think my question is this really low-hanging fruit? For example, let me go to credentialing. For example, we certify, so provider organizations or credentialing verification organizations, we certify them, and that can go upstream to the health plan, and it can meet part of its credentialing obligations through that. The uptake on that is not as good as we would hope. There's CAQH has created a lot of entities, a lot of product offerings that remove this. And my question is, why isn't there better uptake? I think it's a real question. There may be business model considerations. We all have trouble moving off our old business models. And I think that's really at the heart of what we're talking about today. The provider directories, I think there's a federal proposal to kind of create a national provider directory. God bless them. I think it would be great. It's very hard. These things change so frequently that all the plans have trouble doing it. And I think the feds will too, but maybe if people just had to respond to one instead of this proliferation, they could do that better. On the prior auth, I think there are a lot of realities out there about why people are still on the phone and why fax machines still exist, and in fact are alive and well in the prior authorization process. So I think that's a bigger conversation, but I think all of these things are to be explored further. And I would say on prior auth, NCQA is actively engaged in looking at how to make that process more value added and less harassing of providers. So that's really what I had to say about this.
Okay, no, thank you very much. I mean, as you were talking, I was thinking about, for both the low-hanging fruit and of course, the so-called big bang longer run recommendations. Some of this really has to do with improving systems in general, IT and data sharing capabilities, et cetera. And some of it also may have to do with a change in the culture, realignment of the different players in this complex ecosystem. And I think that, especially when you start to think about the issues of really trying to streamline quality measures and measurement processes, I think those have to be addressed in ways that are really sort of consensus strategies and not one-offs at individual centers, or do it now but revert to the more familiar. They have to be sustainable. So I just would be interested, starting with you, David, in your perspective on how to really make changes that will both be meaningful in terms of savings, but also be designed to create systems that really work ultimately to serve patients and hopefully to reduce costs in the process.
Yeah, it's a great comment. So a couple of thoughts on that. One is the best systems are those that don't take providers out of what they're doing, but they work it into the process. So anytime you say to a provider, do your job, and then on the side, do this, that's really complicated. Whereas when you say, and this is really where the information flow gets in, if you say, do your job, and as part of you doing your job, we're going to be gathering this data, which is going to be helpful to you and everyone else, that makes it be much better. So that's the first lesson, is integrated in, and that's where not having the data infrastructure built in is really problematic. And the second thing I'll say is that on the council we did this, if you look at other industries that have gone about standardizing and streamlining and so on, there are often one or a couple of parties that are really driving things. So in banking, when you sort of streamline how you spend money, how you send money from one institution to another, the Federal Reserve is there with its rules, as is the consortium of banks. And it's just, if you want to send money, this is what you do. You have to do this. You don't get a choice of not doing that. You don't get to set up your own system for how you want to send money. This is just how we're going to do it. So there's no competitive advantage in having a better system of sending money. That's not the way the system works. And similarly, in universal product codes, the things that you scan at the store, that is the system. If you want to use universal product codes, you use them. And that's the thing. And there's no competitive advantage in having a better UPC system than anyone else. And those were all started by sort of big companies that said, like, in the case of the universal product codes, like, we're going to like completely overwhelm our cashiers if they have to type in every single number. So better to scan. And in the banking's like, there's literally no way we're going to make it forward if we can't standardize it. And I think healthcare has sort of reached the point where we say, look, there's no way we can function if all we do is we add administrative expense to deal with other people adding administrative expense and to fight back and so on. And so someone has to cut through that. And that someone could be the federal government, which has not done as well as it ought to in this area. It could be consortium of big insurers. It could be someone, but someone has to cut through and say, this is the way it's going to be, and we're just all going to abide by this, and we're not going to compete over who can have a better way of submitting a claim or of collecting this specific piece of information. We're going to all use that, and then we're going to compete over other stuff.
Well, thanks for that perspective. And Peggy, I imagine that you have spent a lot of time thinking about how to address these challenges, and welcome your thoughts.
I just want to say, I think that as long as we're in fee for service, and I agree with the findings of the council, long as we're in fee for service as a path ahead and as a way of keeping your competitive advantage in doing things the old way, it's going to be very hard to move people into the logic that we want to have. And can I have my slide number 3, please? I'm going to talk today about one of the things that I did call it a big bang for quality, so you can go past that. And this is just my response to our section. But I just wanted to make it clear that I strongly believe that if you lose money when you do things in a more efficient and higher value way, you will not find that very attractive. And, so the competitive advantage that David is talking about, that doesn't exist in the banking sector, and they work that out. I think, the idea of getting to consensus today with so many, I think, organizations pretty happy with the way things are, feels a little bit unrealistic. So what about thinking of it as creating a safe harbor or a pathway that's meaningful and real, and where you can benchmark against the value-based stream and put the other things alongside. And that does take the ability to benchmark on measures that are standardized, and that is, it has the advantage of reducing the burden and the harassment of providers that we currently see, and that's just horrible for the whole movement. But it also allows for this benchmarking, and then it allows to get, it allows to pass along some incentive to the consumer, which we already have with Medicare Advantage, I say, to kind of think about which way they want to go. I also want to make a comment that this 20% that we're spending on healthcare, I think I agree with the final statement that Senator Frist, I think, just outlined, but I just want to say it's really not okay, even if we were delivering value for the 20%, because it falls so heavily, and it creates real trade-offs with social services. It really harms our global competitiveness, and we've seen that, and it seems to be a new issue again as we're trying to bring business back to the United States. it has a tremendous impact, especially on poor individuals, and particularly with the high deductible health plan that's been used as a way to kind of cut the overall expenditures, because it means they're not insured at the front end where a lot of the value really is. And so we need to have expectations for accountable entities. And I put this all up here. I'm not going to read it. I assume we're going to share the slides. But it really, we have this kind of currently for plans. Some of the implementation could be better. I'm not going to defend coding practices that currently exist. I think we could do better on a lot of different fronts, but this is the kind of internal logic of NCQA. So let's go to the next slide.
I hate to say this, but we started a little bit late, so I've been asked to cut our session back a bit. So,
All right.
might
Well, let me just
quickly
rush past this. This is what's needed. Much better alignment of what's measured. The good news is, I don't know how many of you saw the article in the New England Journal the day before yesterday, that CMS is going to align behind what they call a foundation of measures, and many of our measures constitute that. So let me flip ahead from this. I just got something that says 15 minutes. Does that mean I'm supposed to? Let me just say this. NCQA started out with HEDIS, which is at the first intersection where you see select the best plans for covered lives. And we were able to move with that notions of population health, chronic disease management, and we were able to work in emerging priorities. That got translated to the delivery system in very awkward ways, many times by individual vendors taking the plan HEDIS requirements and turning them into electronic. Now that there are data at the delivery system level, we really need to take advantage of those data, make the process so much. Ultimately, we believe if digital data are used to deliver care, they can get it right the first time, and it can flow to quality measurement. That is the big vision that we're trying to get to. That does require standardization. This is not by any means easy, but I think that this commitment by CMS to try to get to better standardization is really important. Let me go to the next slides and I'll be done.
Okay, great.
Just pass that, please. Pass it. Pass it. We'll have an NCQA something or other about this. Please go on. Okay, so here's the article that was just 70% of the preliminary measures are HEDIS measures. The others are a small number of hospital measures, dental measures, and CAPS. Those are the remaining categories. So really a lot of clinical quality action around alignment. We're very, very honored and pleased. And we feel like this is a validation of our last 4 years of work, having understood where we need to go, really mapping the path forward. Please go to the last slide. Oh, I disappeared.
Well,
right.
I'll thank you, but you're not done yet. But I think your slides, provided a lot of useful information, and the visual also reinforced, a concern that has come up. I mean, our system is just so complicated with providers and payers and plans and systems. And one of the questions that we got just now echoes, a discussion that has come up a lot, which is we know that a single payer system can be more efficient. It can save money in many different areas, but certainly in terms of administrative streamlining. And the question that came up just now in our Q&A was, how did the council justify not making the decision to support a single payer system? So I might turn first to you, David, to talk about why the Healthcare Spending Council, did not go that route. And then, Peggy, your perspective on, the pros and cons and the realities of the world we live in. So over to you, David.
Yeah, of course, as a council, we discussed this many times. And, it is the case that single payer countries have the lowest administrative expenses. And like, if that were your whole goal, then you'd say, clearly we just ought to have one way of doing it and sort of one standardized process. Sometimes it's not just the one payer, but it's also the way in which you have the limits, that is, you put overall limits on the amount of care available, and then you don't have to deal with each particular patient. Do they need it, and how sick are they, and so on. You just leave it to the doctors to figure out who needs it. So there are different ways of doing things that a single payer country can do. I suppose my own personal thoughts, and I think it was the view of the council, is that the whole single payer debate involves so many more things than just on the administrative end. You know, it's an entirely different way of organizing a healthcare system. One can absolutely have that view. I think what we were trying to think about was, given where we are, is it possible to make progress in some of these areas so that, you know, even relative to a pluralistic insurance country, the US still has higher administrative costs. How can we make progress relative to that without saying that single payer is either good or bad? People can have their view, but it's such a big change that the question is like, could you do something that doesn't involve that and still have meaningful change?
Thank you.
Yeah, as somebody that I think prides myself on pragmatism, single payer feels very, very far out of reach. And so I do applaud the council for trying to concentrate on the art of the possible. And I think I'd like to expand the definition of the art of the possible a little beyond what the council came up with. For example, administered prices. I think that the jury feels like it's still out to me. There are a lot of things that can be done, and I think the administrative simplification is one. I do think that this standardization of quality measures, this is not for all payers, but CMS plays a big role here. And they used to have, for the same clinical concept, one thing for health plans, another thing for ACOs, and another one for the delivery system people. And that resulted in chaos at the level of the person that's trying to deliver the care. And so we feel like this is a watershed moment. We hope we're going to get there. There are many, many bridges to cross before we get to this promised land where quality measurement actually is enabling you to do the right thing in the first place. But I do feel very hopeful that we're crossing an important boundary here.
Well, thank you for that. And I want to turn to another question, which kind of relates to what you were just saying, in that you're looking at how do we move forward and cross this bridge to the next chapter, the next place. And one of the things, obviously, that has to support that is the IT infrastructure and the systems for data collection and sharing. And we did get a question. Millions of dollars were spent on digitizing health records, and there was much resistance from providers. Now we have 98% of providers using digital records, but they have not streamlined the processes of it or the cost of care. As a matter of fact, digital records have added to the paperwork burden, even though it is done electronically. How do we use technology to help us better streamline record keeping and care? And is AI an answer? That's from Nancy Finn, who's a journalist. So, David or Peggy, you want to start out on this one?
Yeah, I mean, I agree with the premise of the question. I think that there are lots of issues to be worked out. I mean, the largest provider of EHRs, I think, really was designed to maximize billings. And so trying to go to value-based payment, it feels like a longer journey than it should be. I think that, there are differing views about interoperability, but I really want to congratulate ONC and CMS for really taking the right stance on this. And we're really making progress on interoperability, which is a sine qua non for moving forward with this. So yes, we have a lot of barriers. We have a lot of barriers everywhere. And I'm not a Pollyanna in any way, but we just need to engage and not put things off the table that need to be on the table, I think.
Mm-hmm. Thank you. David?
Just a couple of comments. One builds on something Peggy has said a couple of times, which I think is absolutely right, which is it's the various recommendations of the council are complementary in the sense that it is far easier to have administrative cost savings if you change the payment model. And so what the parts about changing the payment model, I think, are important here because they drive willingness to do things like this. So thinking of the report as a whole, it may be helpful, and that's where, in some sense, the sort of $30 billion health IT part maybe was off because it tried to do it on its own. And, you know, without sort of, in part because without sort of overlapping with other parts of what policy could do. So I think we'll need to think about it as a whole. I also, again, just want to reiterate this point about thinking about working things into the workflow as opposed to keeping them separate from the workflow. But really, sort of fundamentally, I think that everything involves multiple steps, and there's just not like, you know, we said, you know, in the 1990s, oh, if we just had a single claims form, everything would get better. And so like, then we introduced a single claims form and providers said, great, here's a supplemental claim form I need you to fill out too. And then in the EHR realm, we said, here's money to install the EHR. And then they did it and they said, well, okay, let me use the EHR to figure out how to increase billing instead of figuring out how to sort of streamline things. So everything is going to involve a process. And it's not, and we shouldn't think of ourselves as kind of one and done, like pass the law and then you've solved this problem. We need to think about this as, this is our goal, this is where we're going to go. And Peggy was right when the HIT office sort of did the interoperability. They said, this is our process for getting there, not this, we have done this and now we've solved this problem.
Absolutely.
And so thinking about things in terms of processes instead of endpoints will be helpful.
Absolutely. Very important. Can
Thank
I
you.
just make one more comment?
Yes, please.
So the workflow issue, I think it depends on which workflow we're talking about. If we're talking about a 19th century or 20th century workflow, I don't think we want to get, and you know, watching a very organized delivery system that I came and hung out and understood what they were doing with their implementation of EHRs and so on. They originally had everything coming to the doctor and the doctor was having to do all these follow-ups and so on. That didn't work. It made everybody completely crazy. What they had to do was reorganize the workflow, have the admissions person say, you're due for a mammogram, can I schedule you today? If you think about it that way, and the vaunted team-based care, it really changes that workflow. And it's not going to be one workflow, right? It's going to vary quite a bit. But the room for improvement here is really quite large. And, you know, I say that respectful of people that have been trying their best to do a good job for all these years, but we need to push forward.
Thank you. And that kind of leads into actually another question. We have to align people, we have to align processes, we have to apply modern technology and realistic strategies to get this job done. And we have to make sure that the incentives are right. And one of the questions that came in was, how can we ensure that savings from administrative streamlining under any of these recommendations are passed on to the various stakeholders in the system, not retained by a single party? And I see both of you nodding, so I'll turn first to David and then to you, Peggy.
Thank you.
This, I want to come back to what Senator Frist said, which is these discussions about when are markets competitive and not. And, you know, this gets into another part, of course, of the report. In a competitive market, when the input costs fall, then firms pass those along in terms of lower costs because otherwise someone else would and they would lose all the business. So the more competitive is the market, the more you feel like you need that. The more you feel like that'll happen. The less competitive is the market, the more you worry that any input cost savings are just going to be saved as profit or dissipated in some other way. And so I think we really need to think about that. And it really does come to the other parts of the report, which is, you know, how do you ensure in general that changes that are happening benefit consumers as opposed to benefiting one provider at the expense of consumers or one provider at the expense of another?
Yeah, I agree with that. And I agree that I think this is an area where more thought is needed to kind of really design this right. I keep coming back to the consumer though. And, you know, looking at what confronts a person when they're signing up for Medicare, I think it's really quite confusing. The value is not really laid out very clearly, I don't believe. But what we need to do, I think this point of benchmarking the costs of, for example, MA versus ACOs, but real ACOs that are, you know, land 3 or 4 ACOs, not these ones that just get extra money for doing nice things. And the incentives of the patient, because patients really are the ones that are counting their money and worrying about how are they going to continue to afford healthcare. So I think there are ways of doing that put more incentive on the patient to choose wisely. And I think what's missing from that is really a failure to understand, like, what am I buying when I'm buying Medicare supplemental with classic Medicare? What am I getting in terms of value? So I feel like there's a lot of work to be done to kind of make that more transparent as well.
Well, thank you both. We've come to the end of our time, but we haven't come to the end of our discussion of this set of issues. But I think, it's clear that there are things that can and should be done, hopefully that will be done, and that not only will there be administrative savings and streamlining, but it will actually be better for patients and quality of care. So thank you very much. I want to remind the audience that not for this session, but future sessions, you can post questions on the Q&A portion of your Zoom screen. And I'd like to now pass the microphone, so to speak, to my colleague, Bill Frist, who's going to be moderating the discussion on our second recommendation. Bill?
Good. Thank you. Dr. Hamburg, thank you. And this is going to flow beautifully. This is just a reminder, this is our second of 4 panels that we're having, and this is going to flow really quite naturally from some of David's comments a few minutes ago. And again, for our viewers, as Peggy just mentioned, feel free to put in the Q&A session your questions, and we'll save time at the end of each of these panels to pull in those questions coming through. In this current session, we'll be taking a closer look at what it will take to significantly improve the state and federal oversight of what we were just talking about, the market competitiveness, and whether or not we can put the genie back in the bottle in many ways by increasing the number of competitive markets. We're being joined by Council Member Mark Pauly and Emilio Veronini. Mark Pauly is the Professor Emeritus of Healthcare Management in the Wharton School and Professor Emeritus of Economics, as well as of Health Policy and Medical Ethics at the University of Pennsylvania. He is a member also of the Health Affairs Council on Healthcare Spending and Value, and as everyone knows, has served on a number of community economic healthcare committees, Physician Payment Review Commission, consultant to the CBO, Congressional Budget Office, Office of the Secretary of HHS, and Medicare Technical Advisory Board. Emilio Veronini is also with us today as the Supervising Deputy Attorney General of the Competition Unit in the Healthcare Rights and Access Section, Public Rights Division in the Office of the California Attorney General. Previously, he served 20 years as Deputy Attorney General in the Antitrust Section of the California Attorney General's Office, specializing in healthcare matters. He was the lead attorney representing the people of California in the People versus Sutter Health, and is co-chair of the Healthcare Provider Working Group of the National Association of Attorneys General Antitrust Task Force, and of the Pharmacy Benefit Managers Insurer Working Group, now co-chair of the Insurer Working Group. So a lot to talk about here in the next 20 minutes or so. Mark, let me open with you. And let's focus on the council's Category 2 markets. We remember I put 1, 2, and 3 markets in there. The Category 2 markets being those that have enough population to be competitive, but currently are not. What does the council propose as a way to improve or maximize or move in the right direction in terms of competition in this Category 2 marketplace?
Thanks, Bill. Sure. So I'm happy to talk about this, and also I think it's fair to say, despite the old proverb, there were 4 economists on the council. The old proverb, of course, is 4 economists, 5 opinions. But in this case, we just got 4 opinions. You heard it from David. We, not surprisingly, all believe that more competition is better than less competition, not only in healthcare, but in most other markets where you buy things. And so as a general principle, that's one on which we got, I think, pretty much unanimity, We distinguished, as you mentioned, Bill, in your eloquent summary, between these three parts or three situations in different parts of the country. Places where there are enough competitors, we mostly focused on hospital inpatient care here. There are enough competitors for the market to be labeled competitive, at least by Department of Justice standards. That's basically the 10 big cities plus San Diego and Seattle minus Houston and Dallas. Then there's the other extreme of mostly small towns and rural areas where you just not enough population there to have more than one hospital if you're lucky. But the in-between case, as you mentioned, is the one that's most interesting and also most challenging, where at least under reasonable assumptions about how large a hospital has to be viable, and how frequently people would use hospitals, these would be markets in which, in theory, and by some comparisons in practice, you could have enough hospitals to be more competitive, but currently you don't. And so the question is what to do there. I think it's fair to say that federal antitrust law and appointment regulation by the Federal Trade Commission isn't really very well suited to those kinds of markets. It's much better suited for the first kind, the competitive markets, to keep them competitive and to prevent mergers and acquisitions. Maybe some little bits of the Clayton Act could be used to essentially unwind mergers and acquisitions. So we thought that was more of a challenge. Now, what is the challenge in these sort of middle cases, the group 2 cases? From a management economics perspective, which is what I know, I see, of course, there's always a challenge to any change, but the changes here don't seem, in most cases, it's situation dependent, but in most cases to be all that daunting to me, because in most markets, hospital systems have more than one physical plant. In fact, in many cases, originally those physical plants were separate hospitals, and they've been brought under the ownership and control of one or two systems. And that's certainly true of the University of Pennsylvania healthcare system, although Philadelphia is competitive because we even have the chance of going to New Jersey if it gets too bad here on this side of the Delaware. But I'll pick on Pittsburgh here, which only really has two systems. But each of those systems, the Allegheny system and the University of Pittsburgh Health System, have multiple plants that used to be individual hospitals. There's Pittsburgh Mercy and Pittsburgh Shadyside and Pittsburgh Passavant and Pittsburgh Presbyterian. You could tell from their names. So that from a purely management perspective, not that there wouldn't have to be some adjustments, but they could in principle be spun off and reconstituted as separate hospitals. And the most important thing that would happen if they were separated, it's important to say, is they could come in and would have an incentive to come in with lower price, not just to attract consumers. Most of us don't pay for our healthcare out of pocket, so why do we care? But particularly to become parts of networks arranged by health insurers, especially private health insurers, that do choose their hospital members to compete on the basis of price. And I could go further to sing the hymn of praise to that kind of arrangement. Although when I went on Medicare, I went on original Medicare, so I didn't practice what I preached. But there's a story behind that. In any case, the punchline here, I think, is managerially, and in a sense, economically, from an industrial engineering point of view as well, systems could be split back into their component parts. There are probably some cities where there's one giant hospital building in the middle of town, but most cities that could accommodate more than one hospital have more than one campus, so you could physically do it. The problem is regulation, political and legal. And here, as I already said, I don't see federal tools being much help, but I do see the potential for states to do something. So let me just kind of give a few ideas that we talked about in the council. The most obvious one is just order hospitals to divest and split up into small parts. They did that with AT&T. I think it could be done with a hospital, but obviously there's likely to be a lot of opposition to it politically. And maybe that's a bridge too far, but at least that would be the most straightforward thing, to have a political judgment that, yes, we do want to have more competition in Pittsburgh. And so we're going to order either Allegheny or UPMC to spin off some of its acquisitions, whichever ones make the most sense. The second is more a carrot and stick approach to say, well, if you are willing to take steps to make the market more competitive by making space for new entrants or by creating new entrants out of your original system, we will reward you by allowing you to get some benefits. Perhaps the heavy hand of state regulation will fall less on your shoulder if you're willing to create more competition. And in a way, there's an internal logic to that. If you create more competition, you don't need the heavy hand of state regulation as much. If you want to be, if you're bound and determined in your hospital system to want to buy up hospitals in other states and cross state lines, you could do that as long as a quid pro quo, you're willing to do something to increase competition back at the home base. Because after all, the whole danger of a vertical integration or non-horizontal integration into different markets is as an attempt to expand the market power that you have in your original horizontal market. And if you diminish that, there's less of a threat. So not that I'm in favor of vertical integration either, although I think the economics about that is a little less powerful than it is, as we learned from Adam Smith, about how you want to have more than one baker on whose beneficence you'll rely for your bread. But nevertheless, that's the punchline. And finally, there are alternative arrangements, which you actually see here in Philadelphia, where hospitals could remain separate, but have sharing agreements with each other that could allow for them to operate individually. And as I said, most importantly, price individually. I also want to mention, and then I'll stop, that in addition to the sort of usual measure of concentration, which is in terms of hospital beds for inpatients that we worry about, these days, at least I lay awake nights worrying not so much about concentration in the inpatient bed sector, but in the physician specialty sector. I'm worried that a few giant orthopedic groups are going to take over. And when I got my rotator cuff repaired, I was delighted that I had a choice of more than one provider, and I would be afraid that would go away. So I think in terms of what states might do, they probably need to look at more than just the standard measures of how many beds are here or there in which system, but also what's happening to physicians, because even for hospital systems, a very large chunk of their output is now outpatient care, not inpatient.
Yeah, Mike, I do want to come back and talk about the states as well, other things that they can do. So I'm glad you brought that up. Emilio, first of all, thanks for being with us today. Really appreciate it, because your perspective is so important and unique in many ways. Start, and you can start anywhere, but start a little bit with your general reaction to the council's recommendations. And I'm focusing on, I started the focus on category 2, so you can answer that question, but interested in your general reactions as well. And how can we think differently about what states can do to further competition?
Well, thank you, Senator Frist, for giving me the chance to appear. I also want to thank Dr. Hamburg, the Health Affairs Council. So let me start off by talking about my reactions to the report. And I know y'all already heard the general disclaimer, but to give a specific one, I'm only speaking on my behalf and not on behalf of the office or on behalf of the Attorney General, who I have the pleasure to serve. And let me start off by saying that the report is to be praised for the comprehensive way in which it tackles the need to safeguard, enhance, and restore competition, even in markets that are already fairly concentrated, as well as markets that are less concentrated and thus more competitive. And I want to give a point of observation here, and I'm going to paraphrase Oliver Williamson, who is a Nobel laureate in economics, and he said that economics is about measuring effects. The law, which I have the pleasure to serve, is about administrability. And policymakers have to figure out how to take what economists are measuring and others like sociologists and advise us on what that means for administrability, for process, for using existing legal tools, and for using new legal tools. So in focusing on what the report calls Category 2 markets that potentially could be more competitive, as well as Category 3 markets that are still competitive. The first goal from that administrability standpoint, from an economic standpoint, and even from a policy-making standpoint, as the report recognizes, has to be to safeguard competition. Here, states have the power to varying extents to do ex ante reviews of proposed transactions. That's a fancy Latin word for just saying that we can look at proposed transactions before they take effect. And depending upon the state in question, we can take that look before the transaction is consummated under a public interest standard, where we look at issues like affordability, access, and equity. And this is an important tool to be able to address competitive impact and equity impact issues up front. Now, we in California have effectively used that tool under the leadership of our attorneys general in cases such as Cedars-Huntington, Providence Kaiser, and USC Methodist, all of which can be found online on our website. And this allows us to address via regulation issues that might be more difficult to address via litigation, to get to Mark's point, such as the growth of systems that can leverage or bundle higher prices with marginal or non-existent benefits for patients. Now, California is not the only one that has this tool. There are others that are similar. Rhode Island and New Hampshire come to mind. But let's say you don't have the ability to look at transactions beforehand, or as in California's case, it's limited. You can still go to court to block mergers. And in that sense, there are other tools that may be available and may also be effective. So for example, California just passed SB 184, which set up an office similar to the Health Policy Commission in Massachusetts, not only to address cost growth, which is an issue in the report, but also to do cost market reports on proposed mergers. Now, states, like the federal government, can go to court, often in partnerships, to address mergers that are above the Hart-Scott-Rodino notification threshold. And a number of federal actions involve such partnerships, including, just to name a couple, St. Luke's in the Ninth Circuit, Penn State Hershey and Mark's neck of the woods in the Third Circuit, or more recently, the Providence Plum case here in California. But federal actions can also be effective outside the partnership context. They can be particularly effective where there's an interstate merger or where states don't have the ability to do ex ante review of transactions. However, that being said, I think it is fair to say, speaking for myself, that state ex ante review has an inherent advantage in allowing for more systematic reviews of mergers and safeguarding competition. And finally, and this gets at a point that Mark has hammered home, federal antitrust law provides for retrospective challenges to mergers after the fact. So if a merger is consummated and it turns out that it is anti-competitive, it can be unwound. And a very famous example in healthcare of such a retrospective challenge being mounted was the Evanston case brought by the Federal Trade Commission in the early aughts. I too have called for such challenges in my Red Queen paper, and I do believe that that is an appropriate remedy that can be used with respect to the call for improving competition in Category 2 markets. Thank you.
Good. No, thanks, Emilio. And let's go a little bit further on that because I want to stay on the ex ante. But and Mark, want to open this up to you. We have bad behavior out there today. We know the anti-competitive behavior that's out there after mergers and acquisitions. Behavior that makes already concentrated markets even more anti-competitive coming in. Mark, from your and listen to both of you, let's explore that a little bit further. What tools we have, what should be the appropriate response to that today? Mark, why don't you start, and then Emilio?
Yeah, Well, I'm naturally going to rely on what I've done all my life, which is try to explain economics in words of at least no more than 2 syllables to the rest of the world. And I think there is, of course, there is the general sense that competitive markets are a good thing. That's probably up there with mom and apple pie and other things. But even in healthcare, that actually gets a few raised eyebrows. When I first started, I think it's ebbed now, but most judges believe that nonprofit hospitals couldn't possibly be doing anything contrary to the interests of general welfare because they're nonprofit, aren't they? So some things have to be explained and also proven with data that they're, in the words of the economist Frank Sloan, not a dime's worth of difference in most of the behaviors, including pricing, between nonprofit hospitals and for-profit hospitals. So part of it is explaining things. And I think that's a challenge. Some states have laws, COPA laws, a certificate of public accommodation, which they have used to stop federal antitrust efforts to block mergers. That's bad news from the point of view of increasing competition, obviously, although it's good news from the point of view of saying, well, at least the states have the power to do something about the structure of the hospital industry, if only they would make a 180-degree correction in the way they're going and move toward more competition. Then in part, of course, I was going to say this, more research is needed to show the benefits of competition and to show, particularly for the more baroque arrangements which are emerging all over the place of hospitals to try to get into other markets, whether it's insurance or it's medical specialty or whatever their for-profit subsidiary is doing. It might be putting up apartment buildings and parking garages. You want to be careful about doing that. And I think that's something that those states which have the capability of a wise and skillful regulation should pay attention to. Now, I guess I feel I need to mention, I'm the minority on almost everything, so I'm part of the minority report. And my observation was that although there are some states which do have a heritage of skillful regulation of healthcare and political support for it, and Massachusetts, Maryland, and California, I'd all put in that category. There are other states that I know pretty well, like Indiana and Texas and Idaho, where they don't, but at least as a device to control healthcare spending, steps to assure that markets remain competitive seem to me to be much less objectionable than heavy-handed interference by state or federal governments in the day-to-day operations of hospitals and other healthcare institutions.
I think that's really, really well said.
I don't want the people from Harrisburg coming here to Philadelphia and telling us what to do.
Emilio, continue a little bit further on it. This is just this whole issue of consolidation, or to the extent that behavior becomes anti-competitive. You started down that line. Anything you'd like to add to that? Anything else that we ought to focus on?
Yes, I would like to make a few remarks to answer your question, Senator Frist, for the benefit of everybody listening in. And then I'd like to make a few remarks with respect to what Mark said. So with respect to the issue of what to do about bad anti-competitive conduct, states can and have brought actions challenging such anti-competitive behavior. Our Sutter action is one such example in which we brought a joint action. We're securing significant monetary and injunctive relief with the assistance of our class partners. And details about that settlement can be found online on our website. This action followed on an earlier action brought by the United States Department of Justice in North Carolina, which also resulted in a groundbreaking settlement. And as the report itself observes, states can pass legislation to address and ban such conduct. Massachusetts is one such example. There are examples from other states where efforts are either underway or already successful in doing so. But I'd like to take a couple of minutes. I know we're beginning to run out of time to respond to a couple of things that Mark said. First, states can and do learn from each other. There was an important report issued in Indiana by Dr. Scheffler, I believe, who is on the council. And certainly Indiana is taking lessons from that with respect to the potential for anti-competitive conduct. So this is not a red blue state thing. We all learn from each other. New Hampshire recently took action that I thought was innovative. Again, speaking for myself and not for that state, so did Rhode Island. So really, I think when you have reports like this one, in conjunction with states learning from each other, we can all learn a lot from each other. And then there is the Certificate of Public Advantage. And for those who are listening who are like, what the heck is the Certificate of Public Advantage or COPA? This is a mechanism by which a state can look at a merger, decide what it's going to do with the merger, and basically it does so in such a comprehensive way that according to its relevant statutes, the Federal Trade Commission cannot also take a look. And I think it's important to note that when you think about COPAs, there's the issue of immunizing yourself from federal involvement, which I'm not going to talk about because California does not do that. And then there's the issue of whether COPAs can work well. And there was an interesting paper by Dr. Berenson that suggested that with the resources and with the proper sort of mindfulness of the various issues that are involved, it can. And in an interesting sort of coda to all of this, Oregon has just passed a more comprehensive ex ante transaction review law that may be a model for a number of us in terms of what states can do on this front.
Good. No, thank you. That's really, really helpful. And thanks everybody for sending questions in, and I'm incorporating those into my question. Mark, one of the questions that's come in from the audience is there good evidence with fee-for-service that free market theory works in healthcare? Where's the evidence that competition has lowered cost in U.S. healthcare?
Well, the main evidence actually comes from studies of hospital mergers and acquisitions. And I always cheer for the home team, go Eagles. And I cheer for, in the 4 parts of the report, I cheer for this part, because I think it's got the strongest empirical and theoretical evidence behind it. And the punchline is when hospitals combine, prices go up on the order of somewhere between 10 and 20%, about the same order of magnitude as you were talking with David Cutler about on the administrative costs. So at least in terms of evidence that competition works to lower prices, have prices be lower than they would be in the absence of competition. I think that's pretty much indisputable, although you can dispute anything. In terms of the growth of spending, it's a little more ambiguous because that's a separate category, and sometimes spending should grow, but I think there certainly is evidence in the hospital sector. I think that pretty well answers the
Mark.
Question. Of course, nothing in life is ever perfect, and competition cannot be. We economists don't give guarantees. I don't know, maybe surgeons do, but I think not. That it'll always work, but as I said earlier, more often than not, in my impression, markets where there's competition have lower prices and also lower rates of growth in prices.
Mark, a quick follow-up question from the audience. Since there are obvious benefits of large hospital systems, for example, health IT investments, cyber defense, so forth, isn't it better to have price caps and price growth caps instead of Don Quixote breaking up? You were asked today.
Well, I'm not sure which is Don Quixote. Price caps may not be so. I mean, they would not be so easy in Indiana and Idaho. Let me say. However easy they might be in Massachusetts and Maryland. So political feasibility, obviously, I'm not the expert on, but I think it's probably not guaranteed here. But the other point is, for those, of course, the hospitals that merge always say, we are going to achieve economies of scale, greater efficiency, higher quality, and so forth. Along with my colleague, Rob Burns, we've studied that over and over and over. We have a new paper coming out of the Milbank Quarterly that says, has things changed in the last 10 years? And the punchline seems to be, on average, no. Hospital mergers do not improve quality. They don't make better use of new technology. That's an average, of course. And of course, the hospitals that want to merge always claim they're going to be above average, the sort of Lake Wobegon theory of hospital merger. But we don't really, that's not really a good thing to bet on. Plus, most of those technological things you can rent. You don't have to own them in your own system, particularly if the kind of standardization that was talked about in the previous session is put in place. And I guess the third thing to say is that the proof that those kinds of systems really do that much good, we're still waiting for it. It sounds like a good idea. That's a chance for me to make a commercial. I just put out a book about healthcare management and innovation called It Sounded Like a Good Idea that people might want to look at. And we looked at IT and we ended up saying what I just said. I didn't write that chapter, some experts did, but that it's one of these things in healthcare, whether it's IT or whether it's value-based payment, where the promise is always in the future.
Yeah.
and doesn't seem to ever materialize in my lifetime. So
good. Thank you. Emilio, let me turn to you. What are the challenges involved in identifying these discrete markets in which competition can be either restored or enhanced or expanded, or where intervention to safeguard competition is still possible? When you have multi-county and even multi-state systems competing or dominating multiple markets, take that and just extend it in terms of where do you think we should be moving in the future?
Thank you, Senator Frist. Just to add one quick remark to what Mark said, we're always looking to see in the transactions we review whether there are any actual benefits. Certainly, Mark has correctly characterized the studies nationwide and in this state by individuals such as Professor Scheffler, and we generally don't see them in the matters that we review. So I just wanted to add that as sort of a practical emphasis to what Mark said. But moving on to answer your question, Senator Frist, when we think about safeguarding markets, either under an ex-ante review process or filing a case in court, and we think about these large multi-state and multi-county systems, it comes down to recognizing and addressing cross-market merger effects. That is the idea of leveraging and bundling across different markets, and to addressing anti-competitive conduct, as the report already recognizes. We've talked about anti-competitive conduct, but we haven't really talked about cross-market merger effects. If you want to think about where can cross-market merger effects lead you, one example would be, although we didn't bring cross-market merger theory, would be the Sutter case. We have also remarked on the existence of such effects as motivating conditions imposed by our general in cases such as Cedars, where we believe that the literature does suffice along with the specific facts of a transaction to support ex-ante regulation. But using ex-ante regulation is different than bringing a case into court. And when you bring a case into court, you have to show that those effects are likely, and you have to have some mechanism to separate what we call sheep from goats. That doesn't yet exist with respect to challenging a cross-market merger up front, which means that if you're going to go to court to block further expansion of a healthcare system that is multi-county or multi-state, that's not an easy process, though I would say it is definitely not impossible. There are cases brought in the vertical area, which revolve around the facts of a case and the actual assessment of economic effects in the case, without having to have a distinguishing principle of separating sheep from goats.
Yeah.
What makes this more of a challenge here, though, is that there's not yet literature that says that these effects exist across states. States have different regulatory environments. And so the thought is so far that, these effects have not been seen, have not been complained about, and certainly haven't been demonstrated to exist. But if we think about the facts that many states are not as large as California, so let's think about New England, for example, and there are cases like Anthem Cigna that have identified multi-state employers that could be the target of price increases from interstate systems. It kind of gives a lot of room for thought.
Emilio, I hate to speed it up just a tiny bit because I've got to turn to the next panel. They're sitting here pinging me.
Yeah, so I'll wrap it up here. So aside from folks like Mark continuing to study cross-market merger effects, this brings in the idea of retrospective challenges, which has been almost universally endorsed as being one potential option for addressing these types of effects.
Yeah, this is so good, Emilio. Thank you. This is exactly what you want, to have this fantastic discussion, make you hungry for more, and you really both accomplish that. Mark and Emilio, thanks for taking this deeper look at price regulation and these supports for competition. And now let me turn it back over to Laura for our next panel on spending growth target setting.
All right. Thank you, Senator Frist. And panelists, really appreciate that. And we're moving right along here into our third topic. I am Laura Tolan. I'm the council director. I'm thrilled to be here. And I'm going to be moderating the next session. So I will start, which is on spending growth target setting. And I will start with introducing our speakers. First, John Colmers, retired in October of 2020 as the Senior Vice President for Healthcare Transformation and Strategic Planning at Johns Hopkins Medicine. And John has been a very active and engaged member of the Spending Council for the last several years, and we appreciate that. Prior to coming to Johns Hopkins, John was the Secretary of the Maryland Department of Health and Mental Hygiene and a member of the Maryland Health Services Cost Review Commission, where he also served as chair for a term. And earlier in his career, John was a senior program officer for the Milbank Memorial Fund and also spent 19 years in Maryland state government. Our second panelist today is Deborah Lipson, who is a fellow at Mathematica and has more than 30 years of experience as a health policy researcher and analyst. Deborah's research has focused on Medicaid and state health policy, managed care for vulnerable populations, and long-term services and supports for older adults. She also recently has co-authored a series of reports and evaluations of the Massachusetts Health Policy Commission's efforts related to spending growth targets. Before coming to Mathematica, Deborah held positions at the Institute for the Future of Aging Services, the Alpha Center, and the Intergovernmental Health Policy Project at George Washington University. So a long history in dealing with state issues. So the theme of our discussion today for the next half hour or so. Oh, and I want to just encourage Q&A. Send those in as we're going. You can type your questions into the Q&A. The theme that we're going to be talking about today, obviously, is spending growth target setting, but within that, we're looking at really the state and national divide. So what should a state and national infrastructure for this kind of activity look like? What is the best way to balance both the state and federal roles and also their needs? Before we get into some of that nitty gritty, though, I first want to take a little bit of a step back and ask both the panelists to talk about, but particularly because there was a minority report, but so why are target setting efforts important from a policy perspective? So based on your experience, John, based on your research, Deborah, what policy goals can this kind of activity serve, in addition to the obvious and hoped for, which is to reduce the rate of spending growth? What else can we hope to achieve with this? And you may also want to comment on that overarching goal and the feasibility of it. Maybe start with John, and then we'll go to Deborah on that.
Thank you very much, Laura. I also want to start off by saying thank you very much to you and the staff that Elizabeth Allen and others who helped make this possible, to the leadership of our two co-chairs, and to my colleagues who helped serve on this. panel over a rather interesting period of time in the history of healthcare in this. It's not lost on me that when Alan spoke of the initial issue of health affairs, that there was work there addressing the cost of healthcare. It's also not lost on me that we are a day past Groundhog Day. I just completed my annual review of that movie, one of my most enjoyable of all time. So here we are again. Well, I would say that the first point with regard to the policy goals of looking at this is that to allow for the first time a focus not on elements of the cost debate, whether it is the price is stupid or whether it is around administrative expenses or is it around the concentration of markets, but the end result. And in this case, the ability to identify at a state level and the ability, and as part of that, to look at comparisons not only to national markets, but to comparable markets across the country to that particular state is critically important. And to me, that is the bottom line that we're focusing on. If the ideal is to be able to identify and develop policies to address that overall growth, it seems to me that the first step ought to be identification at the state level of what those expenses are, and to be explicit in establishing what a reasonable goal ought to be for its growth. And at the very least, having a debate that I think clearly has to be done with all participants at the table. Certainly, we spend a lot of time talking about the industries here, but I would include in that discussion the public at large to have input into how we make these types of decisions and where the dollars are being spent. I think having that explicit discussion is critically important. The second policy goal that I would say is relevant to this is that it allows for, even within the state, to have a much better understanding of critical issues of where and how that spending is occurring and how that differs for different populations, geographically and demographically within the state, and how that has transferred over time. Now, for those of you who don't know, Maryland is a state that has borders. Unlike Hawaii, we don't have 3,000 miles of Pacific Ocean around us to separate us. So there's a lot of cross-border activity of Marylanders going into the District of Columbia, heaven forbid, Mark, even going up to Pennsylvania for care, to receive care, and vice versa. And so having the ability to understand those cross-market activities as people move across these permeable borders, I think is also important to understand. The final point that I will make is that in this world of policymaking, there is an awful lot of finger pointing that happens. Who is the cause for the increase in healthcare spending? Oh, it's the evil hospitals. Oh, it's the physicians who are doing it. If we could only get our hands on the prescription drug prices, we would solve the problems. The consumers who are making bad decisions. The list goes on and on and on. The ability to have identifiable, reliable information that's timely, that allows in a public fashion to identify what those are and to set forth goals that are collectively determined seems to me an important first step in solving the cost growth problem. Laura, you're on mute.
Got it. Sorry. Deborah, do you want to take a shot at that question?
Sure. Thank you very much. Again, I also want to start by thanking Health Affairs for inviting me to participate in this event and commend Health Affairs and Council members for reinvigorating a national policy debate on cost control strategies, which I think has been on the back burner for a little bit too long. I concur with a lot of what John just said, but just want to underscore a few points. At the most obvious level, you know, you can produce a report, a wonderful, very informative report on health spending and health spending growth rates, but without a target or benchmark to compare the annual growth rate, you can't judge whether it's good or bad. One year it might be 2%, another year it might be 10%. Is it good or bad? But a target linked to a measure of affordability to the state's economy, to consumers, employers, employees, is needed to really assess whether the growth rate is reasonable or not. And if policymakers want to hold particular entities accountable for excessive spending growth, a spending growth target creates that benchmark to measure and assess their performance and gives everybody a standard to attach those accountability mechanisms. Second, and I think this is just part of what we're talking about in terms of transparency and the importance of just making these kinds of data and information available, comparing growth and spending to a particular target just invites a lot of really important questions and policy debates. If spending is rising more than national or state GDP or more than national or state revenues, for example, is that higher spending producing better quality and outcomes? Or conversely, is lower spending growth restricting access, reducing quality and yielding poor health outcomes? It also invites questions about what the main drivers of growth are and whether it's due, God willing, to things we'd like to encourage, like more primary and preventive care, or things we want to discourage, like avoidable hospitalizations and low-value care. And finally, it's important because it invites questions about which groups are bearing the burden of higher spending and whether some are disproportionately burdened. Finally, I think it's possible, a spending growth target makes it possible to compare that spending growth rate to growth rates in other sectors of the economy. I mean, nearly all state policymakers know very well that the high annual rates of growth in Medicaid spending are taking bigger and bigger bites out of state revenues available for spending on other important priorities, education, transportation, law enforcement, et cetera. And of course, federal policymakers are also concerned about the effect of high growth rates in Medicare and Medicaid spending on the federal budget. But at the same time, just a narrow focus on government spending on healthcare overlooks the way unrestrained healthcare spending, including that by the private sector, crowds out investment in other sectors that contribute as much or more to health outcomes. We all know we mentioned before, the social determinants of health is increasingly understood as an important way to improve health outcomes and making advances in health equity. And I understand the council decided not to tackle this issue in depth, but the evidence on which interventions and investments in social determinants of health reduce healthcare costs is rapidly advancing. So I think a spending growth target gives everyone an opportunity to re-examine that particular issue as well.
Okay, great, thank you. Let's shift a little bit to the sort of the original point of the discussion, which was really kind of talking about these federal and state roles. As you know, the council divided up its recommendations in this area around target setting, which it thought that really most states, all states should be encouraged to do target setting. And then the second piece was monitoring of performance relative to those targets. And then the third was enforcement of those targets. There's a fourth recommendation around the data, support for the data that's needed for all of those activities. So let's start with target setting. I'd like to hear from you both, and then we can move on to monitoring and enforcement. The question being, in terms of target setting, what aspects of doing that are best done or most appropriately done by states versus the federal government? And there was actually a question that came in at the very beginning of the meeting when Alan was going through his introduction about sort of how do you deal with, this is just sort of building on the question I just asked you, how do you deal with disparities among states? So states are going to set their own targets. Are there issues that come up around that regarding sort of equity and disparities among states? So I'll let you, Deborah, do you want to start with that one?
Sure. Well, let me say, first of all, that I very much agree with the council's recommendation to encourage states to set those spending growth targets, following the lead of Massachusetts, Connecticut, Oregon, other states. I really think the states are the most appropriate level for cost growth target setting because the targets are going to vary according to each state's economic conditions, healthcare markets, and politics. At the same time, I don't think it's either practical or feasible to compel all states to set those spending targets. It certainly made sense in Massachusetts, which had almost the highest per capita spending in the country at the time that it passed its landmark legislation back in 2012. So it obviously had a lot more to gain from trying to sustain that spending growth from a very high level. States with low per capita spending may not have as much, to gain from the process. It's also, as it has been said before, a time and resource intensive process between the data collection, the analysis, the reporting of those and public discussion of those events takes a lot of time and expertise. So unless a state makes a long-term commitment and investment in the data collection, analysis, and reporting, the effort's not going to pay off. That said, there's some critical issues that each state has to consider when setting the cost growth target. It's important to set the right spending growth targets for the right set of entities, and I think by an independent governing body. Things that I've learned very well by studying Massachusetts' evolution of its initiative over the past 10 years now. One question has to do with to which types of health spending does the growth target apply? I mean, one would think, I think to be effective, the spending growth target has to apply to all players, public and private, and it should also apply to all or at least most providers to minimize the temptation for certain providers to seek special exemptions or create loopholes that leave out the major drivers of cost growth. One could also argue that the cost growth target should be applied to consumer health spending separately from the overall health target because it tends to get buried within the overall picture. And I think it also has to be adjusted for income, that consumer health spending growth target has to be adjusted for income to protect low and middle income people from the shifting of costs onto them. Another issue is where to set the target. I think we've all seen that the most common and it makes most sense to set that target to national or state GDP so that health spending is in line with the ability to afford cost growth. But this can pose a few problems at the state level. I think states have limited control over some of the major cost drivers, such as drug prices, as we've talked about before. And state GDP growth can change drastically from year to year. I recently came across some data showing that the states that rely, for example, on mining have wildly varying growth changes in their state GDP from year to year. And in such cases, it may be more appropriate to look at 2 or 3 year averages rather than just a strict focus on those annual changes. Finally, who sets the target and what circumstances warrant exceptions or changes over time? In Massachusetts, the legislature that wrote the law, wrote the target into the law for the first 5 years, and they granted limited authority to the Health Policy Commission to change it after that time. And I know even though commission members, including David Cutler, who was on your council, are very knowledgeable and experienced healthcare experts, and they must be free of conflicts of interest, they are appointed by elected officials, governor, attorney general, state auditor, who in turn are influenced by political interest groups. So while a commission is not without its vulnerabilities, it's probably better to assign the task to an independent governing body that is less subject to direct political influence and to require, as John said, extensive public input on that spending growth target. And to recognize that there may be exceptional circumstances like pandemics and environmental catastrophes, which a commission can decide warrant exceptions for certain years.
Thank you. John? You're muted. I'm not the only one.
I was just doing a Laura, I apologize. First of all, I should also disclose, because it was not stated in the outset, that in addition to the time that I worked at the Milbank Memorial Fund, I currently chair that board, and Milbank is doing work in this area as well. I certainly agree with, again, not surprisingly, many of the things that Deborah has just said, given her experience in Massachusetts. I absolutely appreciate the value of the minority report and understand the concerns that have been raised. But I don't think that that necessarily means that one should disavow the opportunity of states, an increasing number of states, both red and blue, from wanting to go forward and undertake this effort. As you properly said, Laura, the report recognizes there's a continuum here of processes, and part of it has to do with not just setting the target and measuring the target, but how do you enforce it? And that may indeed vary quite dramatically from one jurisdiction to another. In terms of setting the target itself, in addition to the points that Deborah made, I would like to add one additional point that was clear from the work that we've done in Maryland in setting a total cost of care target as part of our all-payer demonstration with CMS. And that is that one looks at these targets, particularly as they compare to a state growth rate in the long term. We've just gone through a wild ride through COVID. We continue to experience a wild ride with regard to inflation and the labor markets. If you look at this in the short term, it does not make a great deal of sense to have those fluctuations built into a target setting process, but to recognize that you want to look at the performance over a much longer term. And that means, as a practical matter, that there are going to be years in which you outperform the performance of the state and years that you don't, and that there ought to be a tolerance for that in recognizing those types of changes that occur over time. I think there's also value in being able to, particularly as the number of states increase in doing this, to have the ability to link and to learn from one another how those numbers are set and the degree to which they vary. It's not shocking to see that the targets are generally within a relatively small range of performance. They all tend to be in numbers that are less than what the actual growth rate historically has been. So those, to me, are quite telling that even though these are done independently and different in each of the jurisdictions, it's saying that there is a reasonable standard that is being adhered to that is pretty close to the same, and that number is something less than what we're currently paying. And so the idea is that we need to stem that growth to something a level that is much more affordable.
Okay, thank you. Let's shift a little bit now from target setting, and let's talk about monitoring against targets. And one of the things we talked about on the council was that in many cases, the data that a state might need in order to monitor what's going on is deeper and more complicated to obtain than what you need for the target setting. And this is where we on the council really got into grappling a lot with federal and state roles. So I wanted to have you both address, what do you see as the most efficient way for states to be doing that individually? What kind of support do they need? Should they be doing it individually? And how, in what way can the federal government facilitate that? So I don't. We've sort of been trading off. Do you want to start with John and then go to Deborah on this one?
Sure. So I think that there are, as a first principle, a willingness to say that the role that the federal government can play here is to be the standard setter, and that they have the ability, as they can do with regard to EHR standards, or as my friend and colleague Peggy O'Kane mentioned earlier, are doing in the nature of quality measures. It's in this area that the federal government can and should take a lead role in establishing the standards for collecting this type of information. We'll talk a little bit, and the report talks a little bit about this in terms of collecting data from all payer claims databases and being able to collect that. I frankly think that there ought to be a national standard for collecting that information from ERISA plans. There may be even an argument to be made that they can and should be required to do that already, but I do think there is a very good point to be made that having 50 or even 10 different ways of doing it makes no sense whatsoever. And again, because you're dealing with permeable borders and multi-state organizations, having the federal government create a standard for that is, I think, is something that we would start with. I would also say that in terms of collecting this information, what you collect in part is going to be dependent upon the mechanism, if you have one at all, for enforcing the target. So it may vary. What you collect at a state level or a jurisdiction level may vary depending on the approach that you're using for enforcement. If it is the jawboning approach and the public naming and shaming approach, that may be one way of dealing with it. If it is around insurance market performance and setting premium levels and allowing that to be the standard under which you control the rate of growth and hope that that percolates its way down to provider levels without the rate setting of individual providers, that's a different approach. And certainly the approach in Maryland that we have for hospital rate setting as the mechanism for that is going to be different. So I don't think there is a blanket set of data that one would need to implement this type of policy, in that it would vary depending on what your enforcement mechanism is. But I'm a strong believer in having whatever standards are developed be developed in concert with the federal government so that it need not be duplicated, or whatever the proper descriptive is, not duplicated for 2, but for 50 times would apply.
Okay, thank you, Deborah.
Well, let me echo what John said again, in terms of there being an important role for the federal government or some sort of national resource center that can set the standards. Back in 2000, I had the privilege of working at the World Health Organization and with the folks in the at WHO and OECD that established international standards for national health accounts. And that was extraordinarily useful to harmonize and set common standards for how you report the sources of funds for healthcare and where it goes to, and allow those kinds of cross-country comparisons. Similarly, I think a federal or national center that sets those standards allows for some cross-state comparisons. And you know, you may say that some states like California don't think that they're comparable to any other state, but I think even California is interested in seeing how they compare to some states at least, or to the national level, and having those national standards for data reporting and the categories of spending by payer type, provider type, service categories, et cetera, are really essential to the whole endeavor. You know, I think and let me just commend both the Milbank Memorial Fund and the Peterson Center on Healthcare and other private foundations that have been enormously helpful to states that are out in front. But in the long term, I do think that some sort of national resource center, either an AHRQ or CMS, would be more sustainable in the long run if we're going to do this on an ongoing basis, to do the kinds of sharing of information and lessons across states on cost driver analyses. How do you do that? What are good templates? Give us a head start on templates for state level spending reports, so on and so forth. Just a couple other quick points. You know, states, in terms of monitoring, states just have an edge over national level reports of this sort. Every year Health Affairs does the health policy community an enormous favor by publishing the Office of the Actuary's National Health Spending reports. But states can go deeper and provide more disaggregated spending information in ways that just will never be able to be done at the national level. And they can do so in ways that inform state-specific issues and policy proposals. In a given state, how would broader adoption of accountable care organizations affect the trajectory of spending growth? How would greater investment in primary care, if we went that route, help my state affect, change those cost trends over time? And how would cost growth trend targets affect disparities in access between urban and rural areas of the state? So those are all incredibly important things that have to happen for each state with an understanding of what's going on within that state. I thought it was interesting that Mark Pauly referred again and again to Pennsylvania because he knows it so well. Well, each of us in each of our own states know our own state markets really well to be able to really understand what's going on and what might explain those cost growth drivers.
Great, thank you. We have about 3 minutes. So I'm gonna lob one more question and maybe start with Deborah. On the subject of enforcement, you've just done a lot of research about this recently with Massachusetts. And if I could characterize what I learned from that report was that things that seem to be working well for enforcement initially seem to be tailing off a little bit. I just wondered if you could comment on what are some of the enforcement mechanisms, what do you see, based on your experience as being the most effective, and take 2 minutes and give John a minute and then we'll wrap it up.
Okay, great. Well, I guess I would just say generally, if you're not going to use the results of these, health spending analyses to, inform what you're going to do with the information, there's little value in doing it to begin with. That said, it's the hardest thing to carry out. Efforts to hold powerful interests accountable, often go punished as well as rewarded. So it's a really tough thing to do. That said, I think from my research and studying of Massachusetts experience, they've used the tools at their disposal extremely well, even if they are not what I would characterize as strong enforcement powers. They've done a terrific job of using public transparency, the reports, the cost trends hearings that are done annually every year that are must-attend events. Everybody in Massachusetts who in health policy attends, and there's really an effort to hold the entities that have high health spending to understand what they're doing to try and hold down those costs. That said, there's a number of states that are going a little bit further. Oregon and California have some laws that are trying to say, all right, if there's certain payers or providers whose growth exceeds the target with statistical certainty and without good reason for 3 of 5 years, then the heavy hammer of enforcement will come down. We don't know if that's going to be encouraged voluntary action any more than it did in Massachusetts, but I think it's important that we study this over time. Just one little quick piece of advice. I don't believe, from what I've seen in Massachusetts anyway, that enforcement needs to be overly punitive or regulatory to induce that voluntary compliance. But I think there has to be a credible threat of regulation or price controls or price caps or something if those voluntary efforts don't work. And we learned that from Minnesota, of all places, back in the 1990s, that had an actual law restricting spending growth on private payers. And then when the data showed that those health spending lowered significantly, they repealed that legislation. Well, it's kind of an interesting thing. I guess it's fine to repeal those strict cost growth limits, but the risk of reinstituting such restrictions or punitive action, I think, has to loom large for the spending growth targets to remain effective. And that's why I think a lot of stakeholders of Massachusetts are now saying, please give the Massachusetts Health Policy Commission more teeth.
Okay, great. John, do you have any last?
Last words, I would just say that there's a broad range of ways in which states can implement this. Maryland is an example of the furthest end of the distribution in terms of a rate regulated entity. But I will note that there are other markets now that are looking at this in which government is not the lead director. In St. Louis, for example, there's a business group that is convening the appropriate players to begin to measure and monitor this. How they will go about enforcement, maybe as purchasers, they will do things somewhat differently. But I think there are a range of ways in which people can act once they have that information available.
Okay, thank you both. We do need to wrap it up. Really appreciate your input on this topic. And I am now going to turn it over to Alan for the next session.
Thank you, Laura, for taking us to this point. We're now moving into our final session, which is focused on the fourth group of recommendations from the council having to do with value-based payment. I'm going to be speaking with Jennifer Kowalski, who I introduced earlier, the Vice President of the Public Policy Institute at Elevance Health. Also joined by Hung Mai Pham, internist and President of the Institute for Exceptional Care, which is a new nonprofit focused on helping people with intellectual and developmental disabilities thrive. Mai has also worked in the private sector at Anthem on issues of value-based care, as well as at CMMI, the Center for Medicare and Medicaid Innovation, the Chief Innovation Officer, and really one of the architects of the original accountable care models focused on primary care. So excellent experience to bring to the conversation. Now, much has been said and written about value-based payment and value-based care, and it comes up in every context. There's only, of course, so much we can do in a short segment here. We did not want to reinvent that wheel as we worked as a council. And so we decided we would focus on a particular area in this conversation, even though the recommendations are somewhat broader. And I wrote out what I thought was a great way to introduce the subject. And then 10 minutes into the session beginning today, we got a question from the audience that actually asked it better than my notes. So I'm just going to read the question that came in because I think it captures it perfectly. It says, I appreciate that value-based payment theoretically pulls all the levers, but it's often practiced idiosyncratically within small subpopulations or by one public payer or private health plan. Given the deep fragmentation of healthcare payment and delivery in the US, how can value-based payment be implemented at scale through policy? So I think that sort of captures everything here, which is if we're serious about this, we need to move from individual single payer and often single recipient of payment approaches to try to create alignment to a broader approach. And I'll go through some more specific questions, but why don't I just begin, if I could, by asking, first of all, whether multi-payer alignment you believe is a critical goal, and if so, why? And then we'll start talking about how we might achieve that. So Jen, since you were on the council, maybe you can say a little bit from the perspective of the council deliberations, and then Mai, I'll bring you in after that.
Yeah, sure. Thanks, Alan. And thanks for having me here. And it's been a pleasure to be part of the council. I think speaking about the council deliberations specifically, I think we recognize that there's still a lot of experimentation going on. We're still learning a number of things from that experimentation, and perhaps we weren't quite ready yet to say, like, this is the one thing that is really what needs to be adopted by everyone, but that maybe there were some parameters to put in place to try to kind of hone that experimentation in a way that got us further along the path towards alignment across public and private payers. Did you want me to say a little bit about sort of thoughts on that as well, Ellen? Or
sure, go ahead.
Okay. I wasn't sure how far you wanted me to go with the question.
No, that's fine.
I think there are some benefits to that. Certainly, you can think about, quality measures were talked about earlier. That's certainly, perhaps some low-hanging fruit, if you will, on an area for alignment. But we could certainly go further to think about which of those measures do you weight most heavily, which ones really make the most difference in producing the types of outcomes we want, and can we get some agreement across public, private payers on those. Similarly, thinking about the data that's needed by providers in particular to act on the value-based arrangements. Can we come to some agreement so that that data is produced, perhaps in similar ways, at similar time horizons and so forth, to make it easier for providers to kind of look across the different payers and government programs and so forth that they might be participating in. I think the other thing we should keep in mind is, what does the member or the patient, the individual, want out of these types of models? So can we come to some general agreement perhaps about the types of member experience that we want to see across these models? And again, I think this is higher level. So these are the goals, right? We can align on objectives, we can align on the things we want to achieve, but perhaps where we want to maintain some differentiation, at least for now, is what are the methods, if you will, that we use to get there. And that's where, if you have a number of different payers, you can create some innovation, you can create some natural experimentation, you can get to some, what works better than others. And if we act too soon to say, we're all going to do this exactly the same way, we sort of stifle the opportunity for some of that experimentation. We also probably don't allow for, just differences that exist in patient populations and geographies that, have to be somewhat taken account into these things.
I'd love to hear your sense of the potential benefits, but also the risks around alignment. And then we'll go a little deeper into, I think, the second element, which is, are we ready? Do we know enough? What's the trade-off between uniformity and standardization as opposed to experimentation?
Yeah, so I'm happy to upset the cart a bit. And first of all, thank you for having me, Alan. I will say I agree with absolutely everything that Jen said. But to me, the metaphor in my head is, that's like the parents agreeing on, the rules for how late you can stay out at night. But the metaphor of payers being parents extends a little bit further into the area I wish we would talk about, and I wish the commission had spent more time on, which is, how do you not let the kid get away with something because the parents aren't coordinated? And I think that's a real area of opportunity for alignment. Different payers, just as different parents, have their strengths and weaknesses and the context within which they operate. And coordinating those, which does not mean necessarily doing the same thing, but doing them in coordination toward a unified goal, I think is the opportunity for alignment that we also need to talk about. And so we can discuss all the ways that standardization might need to be prioritized. I don't know that I would argue with most of that, with the sole exception of kind of setting overall goals, for example, for moving X percentage of dollars into value-based payment contracts. That's all very fine and well for public payers, but I can tell you, having lived in both public and private sectors, that as soon as you move over into the private sector, having a mandate expectation like that puts you on your back foot in terms of your leverage with providers. They now know that you need them to enter value-based payment contracts, and they can use that as a wedge to argue for higher unit prices. And then you're kind of left, robbing Peter to pay Paul. So I think it's really important when we talk about payer alignment and sector alignment to talk about what each sector is best positioned to do in coordination with others to move forward toward the goal.
So I think that's a great topic, and I don't mind you upsetting that cart a bit. We note in the research that went into the council work that the evidence base for savings associated with value-based payment, alternative payment approaches is modest. But from the perspective of health affairs, we're also aware that the mechanisms on the private and public side are quite different. On Medicare, you have set rates, and so you can't really create savings by negotiating lower rates, whereas in the private sector, where you have payments multiples of Medicare, if you're doing something on a designed to reward outcomes or reward lower payments, the primary mechanism has to do with prices. So I want to take your comment sort of the next step, which is, okay, two parents, different strengths. Here's one example. The private payers are able to work on prices in a way the publics aren't. The publics have sort of done that and are maybe pushing for other kinds of things like lower post-acute or utilization or something like that. Are those? I'm worried about how far I'm going to take your metaphor. Can this marriage work? Do both of these parties bring something to the table that's complementary that can send a consistent signal to the delivery system, or are we really are these so different that even though the provider has to work with both types of payers, alignment in this sense is not viable? And I definitely want both of your reactions to that.
Did you want Jen to go first, or?
Go ahead, Maya. You seem ready to go.
I would say absolutely yes, and I would also say in my assessment, I would actually flip the script from what you described. I actually think that the public sector has a great deal of control over prices, and the private sector payers are the ones with less control over prices. And in fact, there is this not often referred to interaction between the two, which is that because prices are administered in the public sector and providers know they cannot negotiate higher prices there, they work to push up prices in their private contracts if they are able to, if they have the market leverage to do that. And then they take it one step farther by then pointing to the price differential between their public and private contracts and telling lawmakers that that indicates cost shifting on their part, when in fact it is an artifact of their ability to negotiate higher prices in the private sector. And then you feel this upward political pressure on public sector prices in a feedback loop that feels very much like Groundhog Day. And so in that situation, it's not that hard to then connect the dots to what could be a new way of coordinating across payers, which is, and this touches on another of your comments, that the savings from value-based payments so far have been modest, and I would agree with that. But a major reason why they have been modest, and there are quite a number of reasons, but one of them is that the counterfactual has simply stayed too attractive. It's not just fee for service, it's the prices in fee for service. Payers, especially the public payers, have not done very much to make fee for service prices less attractive. That mathematically limits what can be offered to providers in value-based payment models that make it worthwhile for them to change their ways and change their approach. Even when they want to, it's limiting. And so I think there is a role for public payers here to signal strongly through price administration in their programs, as well as in consideration of things like targeted mandatory participation in value-based payment, that there is essentially you're trying to stop the squeezing of the balloon. And I think all payers, then private payers can react to that, right? Because they will suddenly have provider and negotiating partners who are somewhat more eager to get to a constructive unit price. For example, if Medicare says we're going to mandate downside risk ACO participation by providers who are the highest cost in their markets on the private sector side, that is a very strong incentive signal that then allows the private payers to work in coordination with the public payer. But to do that, I think it's really important that all payers remember, and I think for the most part they do, as sometimes as analysts from the outside we forget, value-based payment is but one tool in a payer's network strategy. You have to have a broad network strategy where you have a vision of what you want your ideal network to look like in terms of provider composition and performance and geographic spread and cost performance. And then you use value-based payment along with other tools like unit price negotiations or offering relief from prior authorization and these administrative burdens in exchange to get the provider network that you want for your network strategy.
Jen, how does this look from your perspective?
Yeah, I think a couple of comments to build on Mai's. I think there's like a symbiotic relationship to some extent, right? Where the public sector can get providers kind of into a mindset of taking accountability for care, starting to bear some financial burden, start to get them down the path. I think there's trickle down implications, if you will, for the private sector, right? We've gotten providers to start to buy in if they've, been able to make investments in changing to some extent the way they operate their practices, or, bringing on technology or clinical support staff. We can build on that in our own, private sector contracting. So I don't think there's like kind of the public and the private, but on the other hand, I think as private payers have the ability to do more around kind of network development and networks steerage. I don't really want to use that word, but we can sort of create preferred networks of high performing providers. We have to, of course, meet network adequacy requirements, but we can do more to say, like, these are the providers that really, drive value. They meet a set of, criteria around taking accountability, delivering value to members, and so forth and so on. And we can encourage members to use those providers through things like benefit design and cost sharing and so forth, in ways that fee-for-service Medicare, if you will, doesn't have exactly the same tools. But, if those things have become attractive to private payers, again, those same sort of ways in which those providers deliver care, they don't just stop kind of at the parameters of our members, they sort of change the practice for all members. And likewise, on the traditional Medicare side, those practices, come into the private sector. So I think, it's certainly not one versus the other. There's sort of benefits that we each get from one another, I think.
So just to continue the parenting metaphor, I think there are plenty of providers who would bristle at the notion that they need parenting at all. And I'm sitting here thinking about the origins of some of the alternative payment approaches were really quite cooperative. They were, as Senator Frist said much earlier in the event, these were providers who were realizing that they were losing money if they did what they felt was the right thing that would reduce utilization and therefore reduce revenue. And so it was really a provider initiative in some instances to come up with mechanisms to say, don't penalize us for reallocating resources away from utilization to things that reduce utilization if they're good for patients. And which to me raises this whole question, again, pushing the metaphor much too far. Can we, you mentioned fee-for-service rates. The other lever point here is mandatory versus voluntary participation in programs. And if you think about the political pushback to low rates, or what are characterized as low rates, the political pushback to mandatory participation in alternative payment can be quite substantial. And appropriately, the investment that certain systems and providers need to make to be successful in alternative payment models may be quite substantial, and they don't necessarily have access to that. So how do we think about the voluntary mandatory nature? If we want alignment, does alignment have to be around mandatory models, I guess, would be a question.
No, I don't think so, frankly, because in terms of practicality, most private payers don't have the leverage to mandate participation. No, what I would say is, and this is a very core principle I think all payers should have, is that not all providers are the same, just as all your children are not the same. It's not to take a patronizing tone, but rather to say you want to reward providers and you want to craft programs for them based on the evidence of what they actually do, not on structural characteristics, right? And so, for example, in other arenas where people have discussed, well, all physician-led ACOs should be in this track, or all hospital-led ACOs should be in that track, or if you've been in the program for 2 years, you need to move to downside risk. As a payer, I say, if you are an independent group and you have generated savings for me, what do I care? You're in downside risk. I say, if you are a hospital system and I see you reducing utilization and I see you taking a hit on your very own skilled nursing facilities and you're still generating savings for me, what do I care? You're in that track or this track, right? That's performance-based policy making. And I think that is what gets you out of the box of thinking about all providers as needing a one-size-fits-all. If you demonstrate commitment and you can demonstrate that across sectors, which is where, you know, payer coordination could go a long way. It's kind of like, Jimmy saying to one parent that he's got this under control and saying to another parent that he's got that thing under control. Well, test it out. You know, see whether Jimmy is being consistent across what he's telling you. And on that basis, offer different options to move forward for providers that reward good performance, that reward the meaningful investments, and that frankly, you know, take into account where we payers collectively have underinvested as in providers who serve, you know, marginalized communities. There are, I think, of course, there will be political pushback, but I think having a strong rationale for why you target a specific mandatory program toward a specific segment of providers makes it more difficult to push back on.
And Jen, I know we can't and don't want to generalize about providers, but when I think about sort of the evolution on the payer side of provider readiness, willingness, eagerness, whatever term you want to use, do you have a sense of whether the environment has shifted? And I have to throw COVID in here too, because a lot of what we did in COVID is just throw a whole bunch of money at providers without expecting them to move towards value-based anything. And so I wonder if some of the momentum that we might have said or felt that we had in convincing the provider community that this was real and this was going to be sustained and you need to figure out how to make this work, that maybe we've lost some of that. I wonder if you see any of that from
no, I might actually argue in the flip side that to some extent, maybe before we threw all the money at the providers, the ones who were taking, some sort of capitated payment or who were, bearing more risk had more flexibility in terms of how they pivoted before all of the, regulatory flexibilities, before we started to address things from a policy and regulatory perspective. If you were a provider who depended on, each patient coming into your office and billing for that particular service, that revenue dried up in the, first parts of the pandemic, right? But if you were a provider who was getting, say, a primary care capitation rate to keep your patient panel healthy, well, you were still getting paid to, maybe call them on the phone before everybody became comfortable with Zoom, or, do whatever you needed to do to make sure that you were still kind of reaching out to them, they were able to reach out to you, and you were getting paid for that, even if they weren't coming into your office for a particular service. Now, whether that, has carried us forward, 3 years later, I don't know that I'm in the best position to say, but I think at least in the early going of the pandemic, we did see a little bit of, maybe this will turn the tide, because there are situations where taking on risk and taking on a capitated payment could be beneficial to a provider. But, we also go ahead, Mike.
Point out, yeah, Jen, I wonder if from your perspective, you saw this too. My impression was that when we threw money at providers during COVID, the haves ended up having more, and the have-nots ended up having less. And so, Alan, to your question of, well, how can we justify mandatory models and lower unit prices when it requires so much upfront investment to do value-based care? I don't think the provider systems that we're all worried about are going to have trouble with cash flow. They aren't the ones that we need to worry about.
Yeah, and I think as we think about like CMS mandatory models or even payer mandatory models, like some of the points I wanted to raise around this question too were, do we know enough about whether these new models help improve some of the inequities that we see and some of the disadvantaged communities and providers and patients, or are they in some cases making those inequities worse? And I know this is something CMS is concerned about, and I'm sure they were looking at with respect to their own models, but it's something we have to think about and know more about before we say, okay, everyone is going to do this particular approach.
We just have a couple of minutes. I want to return, Jen, you mentioned what the enrollee or the patient wants. And I do think one of the challenges we've had in this is that by and large, the consumer has been left out of these discussions.
Mm-hmm.
When we talk about the potential of having consumer incentives for participating in these models, my thoughts go to Medicare Advantage, where consumers certainly have incentives because they can get access to potentially additional benefits, but that then unleashes this whole financial dynamic that we certainly don't have time to address here. What, in just a couple of minutes, can we talk at all about sort of the role of the patient in promoting this kind of a shift and supporting it if we want more of this?
Yeah, so I think one of my last acts at Anthem was working on a program called Cooperative Care, which was, on a very ambitious ACO model focused on two-sided risk and improvement, but improvement centered on the overlap in the Venn diagram between capabilities a provider might have that would both enhance the patient experience and lower total costs of care. So for example, this was 2019. One of the requirements was that the ACOs develop a telehealth capability. And they went kicking and screaming during 2019. And then they felt super smart in 2020 because not only were telehealth visits more efficient once you had the infrastructure up, but that is the magical way to relieve burden on a patient who now doesn't have to take an extra day off from work to sit in traffic and then a parking lot and then a waiting room for a 5-minute conversation that might have been done either by telehealth or asynchronously. So I do firmly believe that opportunities like that exist. They involve sometimes disruptive new models of care that now seem less disruptive on this side of COVID, but hospital in the home is another great example, right? And I think that payers have another opportunity to coordinate when it comes to identifying those kinds of innovation opportunities that they could collectively invest in and promote and kind of clear the path to, because providers with incumbent models of care delivery that are higher overhead, more expensive, don't have a ton of incentive to innovate their way out of that and into obsolescence. But if payers could throw their weight behind that and help those new market entrants, that would be, I think, a terrific way to align.
Jen, a last word before we close this out?
Yeah, I think I like Mai's image of the Venn diagram, and maybe I'll add a third bubble to that. So you've got the payer, you've got the provider, you've got the patient, and you've got value-based care. But we've also got this shift towards transparency, right? Transparency of prices, transparency of information to consumers, and perhaps you can do something. What I'll call like a prospective bundled payment, where this works for some procedures like a hip or a knee, kind of the classic. You're going to have these things done, hip or knee replacement. And we can take if you've looked at any of the transparency files that have come out, we can take all of those individual prices that consumers can't make any heads or tails out of and say, okay, we are going to pull those together. And for this procedure, we are going to tell you, provider, ahead of time, here's what we're going to pay. We're going to tell you, patient, ahead of time, here's your share of that cost sharing. And for the provider that's willing to take that bundle, they potentially are getting patients that like the certainty of knowing the transparency of their costs ahead of time. And it kind of, fulfills multiple multiple goals in kind of one single approach. So I think the more we can think about things that, to Mai's point, kind of touch on the patient experience, what the consumer wants, what the provider is willing to do in terms of taking risk, and all, and creating value for the system at the same time, perhaps the more successful we'll be.
Well, great. Thanks to you both for this conversation. Again, this is a complex topic, but I do feel like you've given us a good sense of both the potential and the design features or considerations and concerns about how we would move forward in as short a time as possible, and will be good food for thought for additional work we're doing in the area. So let me just close out the overall event for our audience. Thank you for joining us. We have recorded the event. It will be available on our website along with all presentation materials in the next few days. I want to thank all of the speakers, our council members, our co-chairs, Senator Frist, Peggy, Dr. Hamburg, for their leadership, our funders, the National Pharmaceutical Council, and Elevance for supporting the work. We do have quite a few events coming up. We have started a new program called Health Affairs Insider, which is a premium product. It's a subscription model, but if you are an insider, you can join us for Lunch and Learn on February 8th, where I'll talk about my top 10 picks and why I choose certain articles as the top 10. On February 16th, we'll have our journal club, where we'll focus on a February study that we published on the role of real estate investment trusts, or REITs, in staffing at U.S. nursing homes. We're going to have a virtual happy hour in the end of February on the 28th. We'll have more events associated with this report and release that will be available not just to insiders, but to the audience as a whole. You can register for all of these and become an insider on our website at healthaffairs.org. So thanks again to all who made today possible, and the great work of the council and council staff to bring us this report that we hope will be the foundation for many discussions to come. And with that, we are adjourned.